And my heartfelt welcome to Dr. Sheila Mane, Madam. She is Chairperson ICOG. And it is, Madam, your vision behind this 7 series that has made this such a powerful academic initiative, strengthening continuous learning across our fraternity. I also want to welcome our esteemed office bearers, mainly Dr. Pratik Tambe, who has joined just now, and all rest, including our Secretary General Fogsi, Dr. Suvarna Khadilkar. And we are also very honored to have our guest of honor, Dr. Bharat Prasad sir and Dr. A.K. Devdas. So thank you, sir, for your graciously accepting our invitation and being the part of this very important webinar. So today we have an excellent academic program lined up, and we are really privileged to have eminent faculty with us. And I extend my warm welcome to Dr. Kumudni, Madam. She's a great academician, and Dr. Divya. So we look forward for a very insightful talk today. I also want to welcome our respected chairpersons, experts, and panelists who will be sharing their valuable expertise today. And a warm welcome to all our viewers and participants who are the true strength of such academic platforms. I would also like to acknowledge my enthusiastic co-conveners, Dr. Neha Priyadarshini and Dr. Shweta Kumari, for all their support. Now, this webinar truly reflects the spirit of collaboration, learning, and commitment to improving maternal health outcome. And I'm confident that today's sessions will be highly enriching and clinically relevant for all of us. So with this, I once again welcome all of you and wish you a very engaging and insightful academic evening today. So thank you so much. Now we'll start with the blessings of Almighty God. I'll request for the lighting of the lamp. There's no sound coming.
Beautiful.
Okay, thank you so much. So, first of all, we'll welcome our guest. So, at present, our Dr. Sheila Mane, Chairperson ICOG, she has joined. Can I have her CV, please? So, we all know her. We all know her. She is Chairperson ICOG for this year, and she's a very dynamic lady. So, Madam, without wasting time, I'll request you to kindly bless for this webinar. Hello. Yes. Madam is there? She is ICOG Chair 2026, Member Health System Strengthening Committee, Vice President Fogsi 2014, Chairperson Safe Motherhood Committee, President BSOG.
Thank you, Pratibha.
2006. And above all, she is well known as a name with PPH lady. So, Madam, welcome. And please bless us for this webinar.
Thank you. Thank you, Dr. Pratibha. And at the outset, I would like to thank you for really taking this initiative.
Please unshare the screen.
And starting this 7H initiative, and you have selected 3 topics, that is hyperglycemia and hypertension and hormones. Okay. And I think as I mentioned 7H, I would just like to say why I have this idea of 7H is I thought it's not only postpartum hemorrhage, but there are so many other causes which are responsible for maternal health. So one is hypertension, hyperglycemia, then HB for anemia, hemorrhage, and then HIV/AIDS, because I have attended NACO workshops and I find now that there is a rise in STDs, okay? And there are so many new guidelines also, which all of us we know. And then another is high BMI. All of we know obesity epigenetics is really affecting women's reproductive health as well as the women's life. And last is hormones, because your contraception, or even if you take perimenopause, menopause, it plays a very important role in women's life. And thank you for selecting these three. And I must thank you for combining so many societies together from Jharkhand as well as from Bihar. And that shows your leadership qualities, that how soon you could collaborate and call all of them. I welcome Madam Kumudini. Madam, nice to see you, Madam. Maybe it is a long time. As well,
Yeah,
I
thank you
would
so
like to
much, ma'am.
welcome Dr. Bharat Prasad also. Sir, nice to see you, sir, virtually. I
Thank
think
you,
I must
thank
have
you.
met you at, I think at, no, Darbhanga I have not visited. I am due to come. I have a visit. I think I have an invitation for a long time. So I
Most
must
welcome.
visit. I must visit, yeah. So I thank all of you, all the seniors for joining this webinar. And it's really, really a very happy moment for me, as well as the president and secretaries from the other societies. Of course, Bhagalpur, Darbhanga, Devghar, Dhanbad, Jamshedpur, Katihar, then Purnia and Saharsa. So thank you all for joining. And I think we should proceed with the scientific program, because we have all the seniors who are going to give us their message. So I may not be able to take everybody's name, but I have seen the program, and I really would like to thank and welcome you all to Bangalore for ICOG annual conference, where Pratibha will get in touch with you. Those who are eligible for FICOG can come here. We have a convocation and an excellent scientific program. It is on 21st, 22nd, and 23rd of August. Thank you all for joining.
Thank you, madam, for giving so much your invaluable inputs on ICOG conference also, because I will request everybody to come for that. And we have our secretary ICOG, Dr. Pratik Tambe also. So I'll request him, just word of appreciation from him also. Dr. Pratik.
Thank you very much, Dr. Pratibha Singh, for giving me the opportunity to speak. We have many legendary seniors here, so I will not stand between you and them. Just want to express my gratitude to Dr. Sheila Mane ma'am for devising and concocting this entire concept of 7H. We've done, I think, 3 CMEs already in this series, and many societies have got connected. Primarily, we are trying to reach out to category B and C societies where knowledge does not percolate and modern concepts still need to be assimilated and actually practiced by all the OBGYNs there. So this is going to be one small step in that direction. I hope everybody derives great benefit from this series. Thank you again.
Thank you, Dr. Pratik. Thank you. Now I hand over the session to our co-conveners, Dr. Neha. If you can introduce our guest of honors.
A very good evening, respected seniors and dear friends. First of all, I would like to thank Sheila ma'am and Pratibha ma'am for giving me this opportunity. So today we are going to start the series by introducing our guest of honors. They actually need no introduction. Dr. A.K. Devdas sir, past ICOG chairman Jamshedpur. He is a father figure to all of us. He has been the vice president of Fogsi in 2006, the president ISOPOP 2004 to 2006, and his inventions like the paperless partogram, growth tape, and descent meter has been a milestone in the journey of obstetrics. We welcome you, sir.
Okay, sir.
Thank you.
Sir, can we have some word of wisdom from you?
From me,
Yeah.
well, I'm
Please unshare the
delighted.
screen.
Hello.
Am I audible?
Yes, sir.
Yes, sir.
I think it's a great opportunity for me to see you all, though virtually. I don't attend now Foxy conferences. If I am ICOG, so I don't meet people. This is an occasion where I have chance to meet at least some of you. And I want to, you mentioned 3H. Now I want to add HR, reaching high. ICOG is reaching high through all these endeavors. God bless you. Thank you.
Thank you so much, sir. Moving on, our second guest of honor, Dr. Bharat Prasad sir.
Hello.
He again needs no introduction.
Hello,
He is
hello,
called,
hello.
yeah, he is the founder and president of Darbhanga
Respected chief
branch.
guest, very good evening to everybody. Respected chief guest, Dr.
Please
Bhaskar
unshare the
Pal,
screen.
President Fogsi, and Dr. Sheila Mane, Chairperson, ICOG. Other dignitaries of ICOG and Fogsi, different categories of faculties and audience. I am very lucky, feel very lucky today to join this very prestigious and important CME organized by ICOG, Foxy and ICOG. ICOG. Thank you very much for this. I am very much thankful to Dr. And I remember to say that I am very lucky to see today my very old friend, Dr. Alok Devdas, very good friend and old friend.
Namaskar, Dr.
And
Bharat.
thankful to convener, Dr. Dr. Pratibha Singh and co-convener Dr. Neha Priyadarshini for inviting me as guest of honor in this very prestigious CME webinar organized by ICOG, Foxy and ICOG, including the different society of Bihar, like Bhagalpur, Darbhanga, Devghar, Dhanbad, Jamshedpur, Saharsa, Purnia, and Kathiyar. And thank you very much. Thank you again. Thank you very much.
Thank you, sir.
Thank you so much, sir, for your blessings. So moving ahead, we now begin our session 1, focusing on a topic of immense clinical relevance, diabetes in pregnancy, which continues to challenge us both diagnostically and therapeutically. We are fortunate to have an excellent speaker, Dr. Kumudni Madam, who brings with her rich clinical experience and academic depth. I now welcome our chairpersons for the session, Dr. Komal Singh Ma'am, Dr. Vibha Jha Ma'am, who is the founder president of Obs and Gynae Society Purnia. Dr. Kubundi Jha Ma'am is our speaker, who is the director and retired HOD of Department of Obs and Gynae Darbhanga Medical College Hospital.
Next.
Dr. Arpita Gandhi Madam, who is the president of Devghar Obs and Gynae Society, Dr. Lakshmi Sen Madam, and Dr. Komal Singh Ma'am, who is the president of Dhanbad Obs and Gynae Society. I now request our speaker to start the session, please.
I'll request one of the chairperson. Can you just introduce our speaker? Lakshmi Madam, you can introduce. You have to unmute yourself, madam. Yeah.
Speaker is Dr. Kumudini Jha. She is Director, Anant Arag Nursing Home, Darbhanga. She is retired as Head of HOD, Darbhanga Obstetric Medical College. She is President of Darbhanga Obstetric Society. She has many paper presentation in AICG. She has multiple award in multiple presentation in national and international journal. She's participant as speaker and faculty in multiple CME and conference. She is examiner both in UG and PG. She is just 2 years junior to me in DMCH. Thank you, Dr. Kumudini Jha.
Namaskar, Madam Lakshmi Sen.
Namaskar.
Very
Good
nice
evening.
to see all the seniors. Namaskar.
Kumudini madam.
Yeah,
I request the support to kindly share his screen.
thank you so much, Lakshmi ma'am, for those kind words. And it is nostalgic to see you here after so many years. You were my senior at DMCH. And like we began the session with the prayer to the Almighty, I thank the Almighty for saving Abha and Pratibha from a big mishap. And it would have been a big tragedy, not only for her family, but also for the Foxian family. You would
Yes,
have
madam.
missed them. This was really a narrow miss. We have near miss cases. You are one of them now. Thank you so much for inviting me on this academic platform. The whole ICOG team, Dr. Sheila Mane, Dr. Pratik Tambe, and we are looking forward to seeing Dr. Pratik Tambe at Darbhanga on the 16th. So I start my talk on gestational diabetes. So next slide, please. So why are we so worried about the diabetes in pregnancy? Now, we all know that India is becoming the capital of diabetes globally. India has 101 million diabetics already, and 130.6 million are pre-diabetics. Becoming the diabetic capital of the whole world, it is a matter of concern. So we have to diagnose these patients early because according to the DIPSI criteria, that is 2 hours post 75-gram glucose, the patient takes it, and when the reading is more than 140 milligrams per deciliter, she is a case of GDM. If it is more than 120, then it is a deranged glucose tolerance test. And if it is more than 200 milligrams per deciliter, it's obviously an overt diabetes, and the patient may have been a diabetic before she became pregnant. So, universal screening is recommended for all pregnant women, like we are recommending HPLC for thalassemia and thyroid profile. So, if negative, the blood sugar should be repeated at 24 to 28 weeks. And if it is still negative, that in the normal range, then it should be checked again at 32 to 34 weeks. Early detection enables timely intervention and better outcomes. Next slide, please. So this has to be it is associated with the daily calorie needs, which are based on the activity level and the BMI during pregnancy. Like a sedentary worker requires a total of 2250 kilocalories per day, a moderate worker 2580 kilocalories per day, and a heavy worker 32 100 kilocalories per day. BMI, if it is less than 18.5, you add 500 kilocalories to that. And if there's a normal BMI, as per activity level, and if the patient is obese, that is the BMI is more than 25, then you subtract 500 kilocalories per day. We do not want the excessive weight gain. Next slide, please. So the 5 key monitoring principles are: testing schedule is fasting, and then another 2 hours post breakfast, lunch, and dinner for comprehensive glucose monitoring. Lab frequencies testing should be monthly till 28 weeks, fortnightly between 28 and 32 weeks, and then weekly after 32 weeks. Additional tests, like simultaneously ophthalmologic examination, is a must because we all know there could be retinal findings that could complications that occur during pregnancy and diabetes, and of course the renal functions tests, because these, when they are associated with an abnormality, they bring the patient to upgrade it to a higher level of severity. Then glucose targets are generally it should be fasting should be less than 95 milligrams per deciliter, but never less than 86, because then the patient will experience hypoglycemic syndromes. And 1 hour postpartum should be less than 140, and 2 hours postpartum prandial should be less than 120 milligrams per deciliter. Dr. Sheshadri's recommendation is that it should be less than 110 per deciliter, 2 hours post 75-gram glucose challenge. We all know about the Ford theory, that is the fetal origin of adult disease. And if the patient is having high hyperglycemia in pregnancy, then the fetal pancreas starts functioning, and that time it is programmed to secrete more of insulin in because of the high sugar levels. And this baby is finally going to become a diabetic when it grows up into an adult. So we know by treating this patient, we are not only controlling her diabetes, her complications, but also saving the next generation from diabetes. Next slide, please. So there are some government thresholds that have been given. Next slide. So understanding the different insulin categories is essential in managing gestational diabetes effectively. We have to first see what are the types of insulin and which category they are. We would like to prefer the category B at least. Long-acting glargine, that is a category C drug. And if you are using that, you have to consult a diabetologist. NPH, which is the intermediate type, its action lasts for 10 hours and is a category B drug, so it is safer in pregnancy. The analogs of insulin like Lispro, Aspart, they peak at 1 hour and finish their action by 4 hours. So they are rapid acting. And the conventional Actrapid peaks at 2 hours and returns to the baseline in 6 hours. It is a category B drug.
Mika.
Category B insulins are preferred in pregnancy due to established safety profiles. Next slide, please. So, what are the combinations that we have? Basal, 50, 50% plus conventional insulin, and half of the total daily dose as basal, and the remainder as bolus doses are given. 1/3 dose can be given 3 times between between breakfast, lunch, and dinner, and equal portions are administered before each meal. Mixtard is a regimen that is 2/3 of the total insulin is given in the morning and 1/3 in the evening for split dosing. We all know the Samogi and the Dons phenomenon. So this is to prevent that so that the patient does not go into hypoglycemia. Analogs of insulin are available as 50% of the dose that is administered twice in the day before breakfast and then at night. And human premix, that is already 30-70 is the ratio. So premixed formulations with 30% short acting and 70% intermediate insulin is given to cover the hyperglycemia in the morning. Next slide, please. So there's a sliding scale to dose the insulin. Next slide, please. Now, in this, when to refer the patient with gestational diabetes to the specialist. Now, intractable vomiting is there. There's nausea. The patient cannot be controlled by the regular antiemetics. Then, or there is a refusal to take insulin, or there is hypoglycemia more than once in 24 hours. The postprandial blood sugar is more than 200 milligrams per deciliter anytime with or without metformin or insulin. And you also refer if the blood sugar levels are more than 150 milligrams per deciliter or the postprandial blood sugar is more than 250 milligrams per deciliter despite treatment. Next slide, please. Next slide. We have some patients who have complications and they come in without any treatment, without any screening. So when they come over with complications, then what are the things that we should look for? We should look for, especially if she is a diabetic or gestational diabetic, you look for the maternal complications like abortions, congenital malformations, because we all know in diabetics, if the HbA1c is more than 10%, then there are 25% higher chances of congenital malformations in these patients. If polyhydramnios is there, we must look for diabetes. In the patients of preeclampsia, they can be associated with gestational diabetes. And if there is a prolonged labor, that could be because of a macrosomic baby, and obstructed labor could happen. Then macrosomia, we all know, happens in uncontrolled diabetes. And because of that, there could be shoulder dystocia, which is a dreaded complication in labor. And especially if the patient comes in labor, so that has to be managed. And we all know there could be chances of an asphyxiated baby coming out, trauma to the fetus, and to the lacerations to the maternal vagina. So this complication has to be prevented. And for that, we have to look into the weight of the baby. And infections, of course, wherever the sugars are high, there are high chances of infections. Then there is the chances of uterine atony leading to PPH, and there could be increased rates of cesarean section because of the diabetic conditions and its complications. Then there are some fetal complications also, which are the ones which we really dread. Intrauterine deaths and sudden stillbirths are common. Now, because of this, we deliver the babies before the 40th week. And there are the lethal congenital malformations also could be there, for which we may have to induce the patients. Now, HbA1c more than 10% increases the incidence of complications by 25%, and early detection and glycemic control are essential to reduce adverse outcomes. Multidisciplinary team approach is recommended for high-risk pregnancies, like those with gestational diabetes and PT, or diabetes plus retinopathy, and there could be renal complications also. So we have to be careful in these patients and consult the diabetologist. In the sliding scale, the dose is usually 0.1 to 0.2 units per kg of the patient's weight, and accordingly we slide it up. So if the blood sugars are more than 140, then you go up, you add it to 4 units, you add to that. If it is more between 160 and 180, then you give 6 units. And if it is more than 190, then you have to give 8 units per day. Next slide, please. So the delivery recommendations based on the glycemic control and the fetal size. Well-controlled diabetes, you deliver at 39 weeks, never or beyond 40 weeks. Macrosomic babies, more than 4 kgs, you induce at 39 weeks, because that will reduce the chances of obstruction. And a poorly controlled diabetic patient or a patient who has complications associated with it, you deliver by 37 weeks. C-section is done for obstetrical indications, and if the fetal CTG is non-reassuring or the baby is more than 4 kgs of weight. So optimal timing balances fetal maturity with the complication risk. Next slide, please. Now, when the patient is in labor, you don't give the morning insulin dose, and the patient if you check the blood sugars before start, she's the first patient who has to be managed, keeping everything in readiness for cesarean section. 60 to 90 milligrams per deciliter, then you don't give any insulin, and you start a DNS 100 ml per hour. If the sugars are between 90 and 120 milligrams per deciliter, then again you do not give insulin, but you give normal saline or ringalactate 100 ml per hour. If it is between 120 to 140 milligrams per deciliter, you add 4 units of insulin and normal saline or ringalactate 100 ml per hour. Between 140 and 180 milligrams per deciliter, 6 units of insulin is given, and the fluid given is normal saline or ringa 100 ml per hour. And if it is more than 190, as we've already seen, it should be the patient should be given 8 units of insulin, and the fluid should be normal saline or ringalactate 100 ml per hour. Next slide, please. So there are certain laboratory values and clinical findings which indicate the need for specialist referral. Like if the serum creatinine is more than 120 millimoles per liter, or the albumin creatinine ratio is more than 30 milligrams, the GFR is less than 45 ml per 1.73 meters square. But this is generally not the ideal measurement, that the criteria that we should take, because the GFR is altered during pregnancy. It is increased, so it isn't really reliable. And retinal complications, if they are present, then we definitely should refer the patient to a diabetologist. Next slide, please. Next slide, please. Now, when the patient has delivered, we have to be careful about the dosage of insulin that we were giving. Next slide. Yes, the long-term management is essential for women with gestational diabetes. The key recommendations include continued lifestyle modifications and diabetic diet. That has to be continued even in the postpartum period. It's not that she's delivered, so now she can have anything. Her previous dose of insulin is reduced to half. And if she was gestational diabetes with a blood sugar of around 140, then you have to observe the blood sugar levels, and accordingly you have to give the insulin or taper it off. Now, these patients are advised to visit the NCD clinic at 13 weeks, because till then the blood sugars generally slow down, but they don't come to normal before 12 weeks. And in the postpartum period, the blood sugar screening has to be done. Lifetime follow-up recommendations are due to increased diabetic risk, that you have to tell them that because you have had gestational diabetes, you are a tentative candidate for become a diabetic in later life. So her screening should continue. And all contraceptive methods are safe, except the combined oral contraceptive pills. We can give IUCDs. Initially, we used to think that it will lead to more infections, but that's not true. So we are using IUCDs, and the implants and the POPs, all of them can be used during the postpartum period. Early intervention reduces long-term diabetic progression. Next slide, please. So thank you all for a patient listening.
Thank you so much, ma'am, for your informative deliberation. And I now invite the chairpersons to give their valuable insights.
Thank you, ma'am. It was an excellent presentation, and you very nicely you have explained the importance of universal screening at the first visit, that is at or before 12 weeks, or if it is negative, we should repeat at around 24 to 28 weeks, and if negative, we should do at 32 weeks. And we should control sugar at all levels. There should be strict glycemic control by diet, exercise, and medicines if required to prevent fetal and maternal complication. And even after delivery, screening should be done at 6 to 8 weeks, and lifestyle modification is essential. Very well presented, madam. In a very concise way, you have explained everything. Thank you, ma'am.
Thank you so much. It's not only during the pregnancy, but it should be pre-pregnancy counseling, because if she conceives during an elevated HbA1c, then there are higher chances of congenital malformation. So she should control that first and then think of conceiving.
Yes, ma'am.
I must, can I just have one word?
Yes,
Sure.
ma'am.
Yes.
Yeah, with permission from chairpersons. Whether Lakshmi madam wanted to say something, then I will talk, because they are chairpersons.
No, proceed.
Madam, you speak, then they will ask.
Okay, fine.
There.
Madam, so nice, madam. You're so senior and still so updated about the recent things. Hats off to you, madam.
Thank you, ma'am.
You also
I heard you
mentioned
about
about, you also mentioned about that first trimester 110 milligram per deciliter level.
Yeah.
That is the initiative of Dr. Sheshaya.
Yeah.
And that is very important, I think, because he talks about steel phenomenon. No, madam, you wanted
Yes,
to
right.
So there is a steel phenomenon where the fetus keeps mother sugar normal, but
Yes.
the fetus is suffering. And you mentioned about the fetal origin of adult disease. So that is why that first trimester. Hats off to you, madam. I mean, you are excellent.
It is all from new people that we are learning.
So as you said, madam, postnatally, so I am coming up with that study. Pratibha will get in touch with all of you. FIGO pregnancy passport, where we have all the assessment of risk factors for the patient, on a regular basis. And recently I was in Chennai, and there is the same talk was going on, and Dr. Vijaya from Chennai said that they have done a study where like in a case of GDM, what we advise is that 6 weeks we should do the OGTT. Now here what they have done a study is they are doing this OGTT after 3 days only, before the patient is discharged. And they found there is no difference, Pratibha.
Yes, sir.
Because the patient may not come back for follow-up. So even
Madam, what about the weight of the baby? I mean, at what time we should do induction? That is a
Not
lot of
induction.
confusion. No, I'm talking just
that. No. Macrosomia is not an indication. Like, because the baby is large is not an indication. That depends on the state of diabetes. If the diabetes is not well controlled, we are going to deliver her early, no doubt about that.
Yes.
The question arises when there is IGT.
IGT.
And in IGT, you will have macrosomias more. Well-controlled diabetes, usually you don't get actually, but there is no indication as such. For them, the macrosomia definition is 4.5. For us, even 3.94 kg also becomes a big baby because shoulder dystocia. So she was talking about it. So I thought I must investigate them before the discharge, only one OGTT. So we will
the neonates also should be investigated at 1 to 2 hours, and again at 2 to 4 hours. And if their blood sugar is less than 44 milligrams per deciliter, that means the baby is going to hypoglycemia and needs to be given IV glucose.
Dr. Arpita Gandhi, madam.
First of all, thanks Pratibha Madam for giving me the post of chairperson, and Kumudini Jha Madam is my teacher. And I had gone in those days when she used to teach me. And really, Madam, it was an excellent lecture. In a very short time, you have covered each and everything. And I request you to send the chart to me, how much insulin is to be given when the patient is gone in labor. And one case I will like to ask you people, all on a sudden, at 37 weeks, one of my patient had sudden IUD.
Yes,
There
that
was
is one
no
of the
history,
risks of
everything. Yeah, actually her grandparents were diabetic. Parents were not diabetic, but grandparents were diabetic. And she had all on a sudden IUD. So I think in our history taking, we should take that history also, that whether your grandparents are also diabetic or not. Pranam Kumudini Di.
So nice seeing you.
Okay, Neha. So we'll move on to next session.
Yeah,
Thank you,
moving on to
madam.
next
Thank you,
session.
Kumudni madam. With lot of
Thank you so much,
problems
Pratibha.
also
Thank
you
you.
have joined. So thank you so much, madam. Thank you.
Thanks a lot.
Thank you so much, respected chairpersons and our esteemed speaker. Moving on, Dr. Shweta will conduct the next session.
Yes, good evening, everyone. Now we will start with the second session. And first of all, I thank Pratibha ma'am, Sheila Mane ma'am, and all organizing committee members for giving me this opportunity. I would like to invite the chairperson for the second session, Dr. Kalyani Singh ma'am. She is president of Saharsa Obsgyne Society, Professor Emeritus Consultant, Kalyani IVF Center. And second chairperson is Dr. Anuradha Sinha ma'am. She is secretary of Purnia Obsgyne Society, director of Sahyog Nursing Home, and she is district coordinator of Lakshya UNICEF Fogsi program. And third chairperson is Dr. Varsha Sinha. She is secretary of Bhagalpur Obsgyne Society, and Dr. Reena Barnwal. She is secretary of Obsgyne Society Dhanbad. She is medical director and consultant of SSMC Hospital Dhanbad. And also her field of interest is high risk obstetrics, infertility, laparoscopy, and hysteroscopy. And now I request chairperson to introduce our guest speaker. She will be speaking on the topic hypertension in pregnancy, what every person should know.
Dr. Anuradha, if you can introduce our speaker.
Our speaker is Divya MB.
Respected seniors and all my colleagues, good afternoon. Dr. Divya, she is an MS DNB, PDF, Obstetric Medicine, JIPMER, NHAMS, Associate Professor, Department of OBG, All India Institute of Medical Science, AIMS, Deoghar, Jharkhand. She was awarded the first prize in TYSA Obstetrics and Gynae quiz at South Zone level held at Chennai in September 19, awarded Fogsi Travel Fellowship in 23, awarded first prize for paper presentation at Kerala Federation of Obs and Gynae Labour Congress 2023, awarded first prize for the paper presentation. She has published many papers in national and international journals and attended many national and state conferences. Completed course on critical care in obstetrics and basic obstetric ultrasound, interested in high-risk pregnancy and maternal medicine. Madam, please.
Welcome, Dr. Divya.
Shall I share my screen?
Sorry.
Please
I
unshare
think
this
somebody
screen.
has to mute themselves.
Yes.
Yeah.
Yes. My mic was unmuted. Sorry for that.
Oh, no. We could hear you, Anuradha.
Ma'am, whether I'm audible?
Yes, yes.
Ma'am, first of all, I thank all dignitaries and seniors for making me this topic today in today's session, and we'll go on to today's section. So this is hypertensive disorders in pregnancy. So pregnancy under pressure. So moving on to the introduction, pregnant women in low and middle income countries are the most vulnerable population in the world who are having hypertensive disorders in pregnancy. And in some of the studies, they have mentioned like 3 to 4 times increased risk of hypertensive disorders in pregnancy. And this preeclampsia follows second and cause significant maternal and perinatal morbidity and mortality. So this hypertensive disorders in pregnancy have an incidence of approximately 10% worldwide, and preeclampsia occurs in 2 to 4% of pregnancies. So in today's section, we'll see the definition, classification, diagnosis, management, complication, and long-term consequences. So moving on to the definition, by gestational hypertension is blood pressure systolic more than or equal to 140 and diastolic more than or equal to 90 after 20 weeks of gestation. And she should not be a case of chronic hypertension, and we should measure the blood pressures 4 to 6 hours apart. And there should not be any proteinuria or other signs of organ dysfunction. And next comes the preeclampsia. So in preeclampsia, the same thing that definition meant for this gestational hypertension. Along with that, there will be proteinuria or there will be end organ damage. And if there is end organ damage, then it will come under severe preeclampsia. And this chronic hypertension is hypertension which occurs before pregnancy or still persisting after 6 weeks of postpartum. So previously it was 12 weeks after postpartum. Now actually we have mentioning it as 6 weeks after postpartum. So here you can see all the types of hypertension. So in chronic hypertension, there can be a primary or secondary reasons, and it could be a white coat hypertension, means high BP detected when we are measuring her blood pressure. And in masked hypertension is like she will be having high BP, but when we are measuring the blood pressure, it will be normal. So when it's diagnosed during pregnancy after 20th week of pregnancy, then comes the gestational hypertension and preeclampsia combinants. So there is one more terminology, it's transient pregnancy hypertension. So in this, the patient will be having high blood pressure, and in subsequent BP levels will be normal and without giving any drugs. So these patients will be more prone for developing hypertension preeclampsia in the rest of the second half of pregnancy, and the risk is around 40% more when compared to the normal population. So here, chronic hypertension is hypertension detected before pregnancy or still persisting after 6 weeks of postpartum. And in preeclampsia, there will be no onset hypertension during pregnancy with proteinuria with end organ damage. And in HELP syndrome, there will be hemolysis, elevated liver enzymes, and low platelet count. And eclampsia means this hypertension with presence of seizures. So there can be atypical presentation also. So there, with normal blood pressure and having eclampsia, seizure for the first time during pregnancy. In those cases also, we should consider eclampsia as the first differential diagnosis unless otherwise proved. So here in proteinuria, so we should measure the proteinuria. We can measure over a period of 24 hours. So if the 24-hour urine protein is more than 300 milligram per deciliter, or sport urine protein creatinine ratio is more than or equal to 0.3, or urine dipstick more than or equal to 2 plus. And what do you mean by this end organ damage? So there can be acute kidney injury with a creatinine of more than 1, liver involvement with alanine aspartate level more than 40 international units per liter. So previously it was twice the normal level, but now actually we are considering it as even more than 40 should be taken into account when we are getting a patient with a preeclampsia. And there could be neurological complications including eclampsia, altered mental state, blindness, stroke, clonus, severe headaches, visual scotoma, or hematological complications including thrombocytopenia, DIC, hemolysis, or there could be uteroplacental dysfunction causing fetal growth restriction, abnormal umbilical artery Doppler, or stillbirth. So there are subclassification in this preeclampsia. So it could be early onset preeclampsia, means less than, so detecting before 34 weeks of pregnancy, or late onset after 34 weeks of pregnancy. And there are more terminologies like preterm preeclampsia and term preeclampsia, like after 37 weeks of pregnancy. So the complications will be more in case of early onset preeclampsia. So we should know how to measure the blood pressure. So when the patient is coming to our OPD, make her sit for 5 minutes and she should be seated with arm at the level of heart and legs uncrossed, and no coffee or should be taken half an hour prior to the measurement, and cuff size should be appropriate, and you should hear for the cork of 1 and cork of 5 for diastolic blood pressure. So this is the physiological changes during pregnancy. So we know that in the second trimester, around 16 to 22 weeks, so there will be a little fall in the blood pressure. So this is very important because when we are getting the patient from the first trimester onwards, so we will be measuring her blood pressure in all visits. So we should look for this fall in blood pressure, because if patient is not having a fall in this blood pressure, then these candidates will be a candidate for developing preeclampsia in the later half of the pregnancy. So this is the pathogenesis. So this is a two-stage theory of preeclampsia. So here, so in normally what happens is there will be invasion of the thromboblast, causing the spiral arteries will be less resistant and the blood flow will be good, and there will be placental growth factor production, VEGF, and followed by healthy endothelium. So what happens in preeclampsia? So here there will be incomplete invasion of the endovascular thromboblast. So there will be high resistant flow causing decreased oxygen, causing hypoxia. So there will be SFLT1 increased level causing inhibiting the VEGF, and this will cause the damaged endothelium and causing the end organ damage. So end organ damage include eclampsia, HELLP syndrome, proteinuria. So it can be at the level of kidney, brain, heart, anything. So moving on to the symptoms. So in some of the cases, patient will not have any symptoms. So in other cases, the symptoms include swelling of feet, headache, fits, vomiting, breathlessness, blurring of vision, epigastric or right abdominal pain, or reduced urine output. Signs include hypertension, proteinuria, non-dependent edema, rapid weight gain, brisk reflexes, angle clonus, and in fundoscopy, we can see for signs of increased blood pressure. So there can be retinal edema, papilledema, etc. And right upper quadrant pain due to liver capsule stretch. So next is HELP alert. So we will be seeing vomiting in the first trimester, and if you are getting vomiting in the second half of pregnancy, so there should be a high index of suspicion for this HELP syndrome, because this patient can deteriorate very rapidly, and early diagnosis will give the best result. So abdominal pain, so patient will have colicky. So this is one of the common symptoms seen in patient, and this is localized to the mid epigastrium right upper quadrant or below the sternum. So tenderness will be there associated with nausea, vomiting, and generalized malaise. And when we are doing a laboratory diagnosis, then the SGPT level and LDH will be elevated. So next comes the HELLP syndrome. So in laboratory diagnosis, there should be hemolysis. So hemolysis should be established by at least two of the following. So there could be cystocytes or Burr cells in peripheral smear, serum bilirubin more than or equal to 1.2, lactate dehydrogenase level more than 600 international unit, or severe anemia unrelated to blood loss. And the other parameters are elevated liver enzyme, SGOT, PT more than 75 international units, and low platelet less than 1 lakh. So what are the differential diagnoses? You should always consider three major differential diagnoses. That's acute fatty liver of pregnancy, thrombotic thrombocytopenia purpura, and hemolytic uremic syndrome. So other differential diagnoses include gastroenteritis, hepatitis, pancreatitis, appendicitis, etc. So this proteinuria already we have discussed. So abnormal level is more than or equal to 30 milligram per millimoles. So next comes the management. So if you are getting a pregnant woman with hypertension detected after 20 weeks of gestation with no proteinuria, so you can go for an outpatient management. So we'll start antihypertensive medication like methyl-dopamine, labetalol, nifedipine, and BP monitoring, home BP monitoring should be done. And if there is high BP blood pressure, then she should report back to us, and we should titrate her antihypertensive accordingly. And we should assess for any proteinuria, and we should check for any end organ damage to diagnose preeclampsia. And same sitting, we will be looking for any fetal growth restriction or fetal adverse events. And if there is preeclampsia, so this can be of two types, non-severe preeclampsia and severe preeclampsia. In non-severe preeclampsia also, we can follow up the patient in outpatient basis. And if we are getting a patient with severe preeclampsia, means blood pressure more than or equal to 160 systolic and 110 diastolic, and platelet count less than 1 lakh, impaired liver function, right upper quadrant pain, kidney failure, pulmonary edema, FGR. So in these patients require hospital admission. So we will have a tight blood pressure control. We should monitor her blood pressure more frequently, and we should assess for other end organ damage also. And decision for delivery will be according to the maternal and fetal conditions. And in eclampsia and health syndrome, there is a need for immediate termination of pregnancy. Next, moving on to the antihypertensive therapy. So, first line drugs include labetalol, nifedipine, methyl-dopa, and hydralazine. So, labetalol forms the first line drug, and it's contraindicated in poorly controlled asthma. So, usually oral drugs are more tolerated, but IV drugs will have more effect on this women. So, we'll start with 100 milligram thrice daily, and maximum dose is 1200. And regarding nifedipine, so here actually we can start with 10 milligram BD and with a maximum dose of 120 milligram per day. And methyl-dopa, so we can start with 250 milligram 3 to 4 times per day and maximum of 2250 milligram per day. So lifestyle and dietary modifications are very important. There are studies showing that patients with a balanced diet and with a good physical activity having a low risk of developing preeclampsia and hypertensive disorders in pregnancy. So a balanced diet with a nutrient-rich foods like fruits, vegetables, all grains should be included, adequate protein intake and hydration. And reduce the salt intake, and there should be regular physical activity like walking, prenatal yoga, and guidelines aim for 150 minutes of moderate exercise per week. So this supports the maternal health and fetal development and reduce the risk of complication and chronic diseases. So next comes the fetal surveillance. So we know that there is a risk of developing fetal growth restriction and Doppler abnormalities. So if we are getting a reversal or end diastolic, absent end diastolic flow, then we need to terminate this pregnancy by 32 to 34 weeks of pregnancy. And ductus venosus A wave shows a poor prognosis with a fetal acidemia. And magnesium sulfate should be given if the gestation age is less than 32 weeks. And CPR of more than 1 gives us time to postpone the delivery. And regarding echo, so this cardiology workup is very important in these cases. Like in patient with preeclampsia, it's seen that there is a risk of developing diastolic dysfunction and systolic dysfunction, and maybe developing of cardiomyopathy. So when we are getting a preeclampsia, better to do a echo to rule out this pathology. So maternal evaluation include cardiac, renal, and fundoscopy and liver imaging to look for end organ damage. And regarding management of severe hypertension, so you should look for the blood pressure, systolic blood pressure more than or equal to 160, diastolic BP more than or equal to 110. And when you want to give magnesium sulfate, there are some contraindications. So patient already having pulmonary edema, renal failure, and with myasthenia gravis, so you won't be giving magnesium sulfate. So magnesium sulfate will give a loading dose followed by infusion according to suspend regimen for a period of 24 hours after delivery or after the if there is a seizure episode. And antihypertensive medication should be continued. So labetalol is the first line drug. So regarding the timing of delivery, so according to this Habitat 1 and Habitat 2 study, so they have found that so in patient with non-severe preeclampsia, we can continue the pregnancy until 37 weeks until there is deterioration of the mother and fetal condition. And Habitat 2 concluded that immediate delivery did not significantly decrease the risk of adverse maternal outcomes, and immediate delivery did significantly increase the risk of neonatal respiratory distress syndrome. And women with non-severe hypertensive disorder of pregnancy between 34 to 37 weeks of gestation should be monitored expectantly. So there are certain indications for like termination of pregnancy. So maternal indications include preeclampsia with 37 weeks or complication anytime during pregnancy. And BP not controlled with 3 antihypertensive, severe preeclampsia, HELP, impending eclampsia, eclampsia, abruption. There's deranged creatinine and liver enzymes, papillary edema, pulmonary edema, and hypertensive emergencies. And fetal indications include severe oligo anhydramnios, ADF, more than 32 weeks, non-reactive NST, or poor biophysical profile. So how to deliver? Induction of labor could be done at 37 to 38 weeks. So even with low Bishop score, we can start with priming, and cesarean section is done for obstetrical indications. And in intrapartum care, adequate analgesia should be given, and BP should be monitored, and antihypertensive should be given, and should monitor the urine output. And most of the cases, they will be, in some of the cases of severe preeclampsia, they will be getting this magnesium sulfate also. So there is a need for monitoring the input-output chart, and also you should look for chest for any crepitation to look for any pulmonary edema. And in second stage, cut short the second stage of labor, and third stage, no ergometry. And regarding the postpartum period, same. Actually, we should monitor her blood pressure, and we should continue the antihypertensives. And the target blood pressure in the postpartum period is 150-100 millimeter of mercury. And we should, if her parameters, laboratory parameters are already deranged, after 48 hours, we can do a we can repeat the laboratory test, and we should see for the improving or stable status of the blood test. So regarding the prevention of hypertensive disorders in pregnancy, so there are preeclampsia prediction models. So in clinical risk assessment, so there are certain conditions with high risk of preeclampsia. So it could be a hypertensive disorder during the previous pregnancy, chronic hypertension, chronic kidney disease, type 1 or 2 diabetes mellitus, autoimmune disease, or ART. And moderate risk include nulliparity, age 40 years or more, pregnancy interval of more than 10 years, BMI of 35 or more, family history of preeclampsia, and multifetal pregnancy. And there are fetal medicine risk assessment also. So here actually we'll see for the type singleton or twin, age of pregnancy, crown run length, maternal age, racial origin, smoking, consumption, medical history. So these all will take into account. So in clinical risk assessment, so there is a risk of developing preterm preeclampsia of 40% and term preeclampsia of 35%. And taking in this components into account, so there will be a risk of developing preterm preeclampsia of 90% and preterm preeclampsia sensitivity of 75%. And in late preeclampsia prediction, we can do a SFLT level at 35 or 36 weeks and sensitivity of 75 to 80%. So these are the uterine artery Doppler. So in first trimester, the mean PI 95th centile at 11 to 13 weeks is 2.35 in transabdominal and 3.10 in transvaginal ultrasound. And in second trimester, mean PI 95th centile at 23 weeks is 1.44 by transabdominal and 1.58 by transvaginal. So mean uterine artery of 95th centile at 30 to 34 weeks is 1.17. So first trimester screening of uterine artery PI more than 90th centile. So it's found that 48% of women will develop early preeclampsia and 26% will develop any preeclampsia at any time, and it's having 10% screen positive rate. So with moderate exercise more than or equal to 140 per minute, we can reduce the preeclampsia by 40%. And if assessing the risk, if at high risk of preeclampsia, initiate aspirin before 16 weeks of gestation, and this will reduce the preterm preeclampsia by 60%. And if the intake of calcium supplementation is less, then supplement calcium. Supplement calcium, and it having a reduction in preeclampsia by 50%. And with timely birth, it will reduce the preeclampsia risk by 35%. So these are the multi-system complications. So in heart, there can be cardiomyopathy or diastolic dysfunction. Brain, there can be hypertension, encephalopathy, ischemia, vasospasm, hemorrhage, edema, and this is the most common maternal mortality due to preeclampsia. And there could be pulmonary edema, ARDS, and in kidney, there can be acute renal failure. And in liver, there can be subcapsular hemorrhage and altered LFT, HELP syndrome. And fetus, there will be like a fetal growth restriction, preterm delivery, etc. So India has the highest number of stillbirths in the world, and the most common cause is hypertension, accounting for 18.2% among the all causes. So regarding the future devastating consequences, this preeclampsia later in life can cause development of cardiovascular diseases such as ischemic heart disease, chronic hypertension, and stroke. And child born from preeclamptic patient often suffer fetal growth restriction and small for gestational age. And this preeclampsia also increase the risk of stroke, coronary heart disease, metabolic syndrome during adult life in the child born from preeclamptic patients. Thank you. Thank you.
Thank you, Dr. Divya, for such comprehensive, detailed information about the hypertension in pregnancy. And now I request the chairperson to give their inputs.
Thank you, Dr. Divya, for an excellent presentation. In such a short time, you have covered this topic so nicely. From terminology, each terminology you have described, and the management of each one was excellent. I don't think anything was left. In short, your topic was such a lengthy one, but you have done justice to the topic and covered each and every type of hypertension in details, their management, their complications. So thank you once again.
Thank you, ma'am.
Dr. Reena?
Thank you, Dr. Divya. It was an excellent presentation, and it was a good revision for us. Thank you, Dr. Divya.
Thank you, ma'am.
Anyone
Pratibhaji,
else?
can I speak
Yeah.
something?
Yes.
Divya, it was really excellent. Just I want to share that in our busy clinic, usually the blood pressure is taken by our staff who have a favorite number of 110/70 or 120/80. After our regular antenatal checkup, if a patient comes with eclampsia, believe me, then I feel like Dharti Mata phato aur main sama jaun. So and they have got no idea about that protocol sound. So we should regularly train our staff for how to take the blood pressure properly. And it is better that after 20 weeks we should take at least once we should take the blood pressure ourselves. Second is ophthalmoscopy should be included in the investigation, because as my husband is an ophthalmologist, I usually make use of him. If there is spasm of nasal branch of superior retinal artery, then this patient is going to develop eclampsia. And the third is the dose of magnesium sulfate should be written in each and every level, and each and every staff. There should be drill for eclampsia every time. And next time I am going to do in our society. And for this ophthalmoscopic examination also, because now MC is there, I will do some research work for this develop that the patient is going to from preeclampsia to eclampsia, and about the doses of magnesium sulfate, it should be known to each and every staff of our clinic. And your paper was excellent, Divya, as usual.
Thank you, ma'am. Thank you.
Thank you.
I have a submission, Dr. Pradeep.
Madam, we have with us, I think, Dr. Bhaskar Pal, sir.
Oh, nice to have him.
Bhaskar, yes, sir. So,
Hi.
good evening, sir.
Please carry on. I'm very sorry to interrupt in the middle of the things, but I congratulate Dr. Sheila Mane, Chairperson, ICOG, and also Dr. Pratibha Singh, who's coordinating this program for this unique 7H series of programs discussing very important things like gestational diabetes and pregnancy, PIH, and hormones. And thank you very much to all my seniors. I can see Dr. Alok Devdas and Dr. Bharat Prasad and sir and all dear friends. And please keep up the good work. Thank you. Apologizing for interrupting and joining late.
Thank you, sir.
I would like to acknowledge Dr. Bhaskar is here. ICOG, Fogsi, ICOG, and Justosis, we have released HTP guideline. Okay, Pratibha, I will share it with you. Please share it with all the societies.
Yeah, it's anyway there on the Fogsi website.
Yeah, they're also on the Fogsi website. Otherwise, WhatsApp, I can share it with you. where we also talk about prediction, a simpler way like Justosis score, as well as that MAP and all those things, because it's very easy. And Justosis score now is been introduced even in government institutions. In Karnataka, we already started, even in Madhya Pradesh also, where if the Justosis score is more than 3, we start them on EcoScreen 75 milligram. So there are many things which are made simple. So I think excellent talk by, I forgot her. And I think
Dr. Divya. Dr.
Divya.
Divya.
I saw her credentials. So Divya, I want to tell you, Pratibha, now your next work is now to have a critical care workshop now in one of the medical colleges where everybody will join. Okay, and she has done that critical care. Divya, I was looking at her. I think she is qualified from Pondicherry, obstetric medicine. So where are you, Divya? Can I see you?
Yeah, she's there, madam.
Ma'am, actually
Show your
currently
face.
working at Ames Devar, ma'am, assistant professor.
Okay, fine. So anyway, that is also there in my ICOG
Sure, ma'am.
program. So we can just do that. Thank you. Okay, and we can proceed.
Anybody else want to add something? Any other chairpersons are there?
Ma'am, I would like to ask one question from
Yes.
Sheila
Yeah.
and other seniors. Is there any, we have not discussed anything about the placental growth factors regarding screening of preeclampsia. So how
Divya,
frequently it is done?
Dr. Divya.
Actually, the availability of this SFLT placental growth factor is a very important thing. Actually, it's suggested that if we could do this SFLT placental growth factor ratio at least one time during pregnancy, it could detect the risk of developing preeclampsia. And there are studies showing that if it's having a high negative predictive value. So if you have done, so next few weeks, it will tell like there is no risk of developing preeclampsia. It's mainly useful in the later stages, like the second half of pregnancy.
See, the point of care test for PLGF is there only for prediction, which can be done at 12 weeks. It is available in India. The study is going on in KLE, where they are doing this PLGF test point of care for a prediction of eclampsia. But as we know, private and as Divya was mentioning about SFLT and PLGF, yes, first of all, in Bangalore also it costs 6,000. Okay, so recently I had a patient with mild jaundice, so it was a differential diagnosis. So I wanted to know whether enzymes were raised, whether it is HELP syndrome, whether it is FLP, whether it is hepatitis A or E, because right now we had many patients. So sometimes for differential diagnosis also, and that patient, it really helped me, it turned out to be help. So I had to deliver. If it was a hepatitis, I would not have delivered her. So, but it is expensive. But as Divya mentioned, in later half, it will, at least it will tell us if it is negative, that next 1 week, this patient is not going to have, preeclampsia. So that is how I think it helps. And I must tell you, Dr. Revati from Bangalore has done a lot of work on this. And she is now a council member of ISHIP, International Federation of Hypertensive Disorders of Pregnancy. Okay, yeah.
Okay, and one line I would like to add that pre-eclampsia is not 100% preventable, but eclampsia is 100% preventable. So diagnose it early and do not let any patient to go into the eclampsia.
Madam was asking about that suddenly they come. So it is the prediction where you have to also look at their MAP, mean arterial pressure, even if the blood pressure is normal. Okay, so that is how I will share those guidelines, Pratibha. Simple things where it will definitely help in our regular practice. And thank you, Dr. Bhaskar Pal, for joining. Very nice. Thank you.
Thank you all the chairpersons and Pratibha ma'am, Sheila Mane ma'am. And now I would like Dr. Neha to take over for this third session. Thank you.
Thank you so much, Dr. Shweta. We now come to session 3, an engaging panel discussion on hormones in focus, contraception, and beyond. And for that, we have our esteemed dynamic convener of program as moderator, Dr. Pratibha Singh ma'am. And as experts, we have Dr. Ranjana Joshi, past President Jamshedpur, Dr. Ranjana Jha, past secretary Katihar, and our esteemed panelists include Dr. Archana Jha, past secretary Bhagalpur Obs and Gynae Society, Dr. Maushami Das Ghosh, president Jamshedpur Obs and Gynae Society, Dr. Imrana Rahman, past secretary Bhagalpur Obs and Gynae Society, Dr. Rajshri Purve, secretary of Darbhanga Obs and Gynae Society, Dr. Kavita Barnawal, madam, chairperson Urologic and Pelvic Floor Repair Committee, Dr. Rita Thakur, member of Devghar Obs and Gynae Society, Dr. Swati Singhal, member of Jamshedpur Obs and Gynae Society, Dr. Khushbu, member of Purnia Obs and Gynae Society, and Dr. Amrita, secretary of Saharsa Obs and Gynae Society. I now welcome Dr. Pratibha to moderate the session.
Can I share my screen? Hello. Can you see my full screen?
Yes, ma'am.
Yeah. Okay. So now we'll be starting our panel discussion, and I will start with that the contraception today is not just a birth control, but it is a symptom control, cycle control, and risk control. So good evening once again. And today our panel is mainly focused on the practical and evolving areas in gynec, that is contraception and the broader role of hormones in the clinical practice. So with this, we will start. And despite multiple available options, choosing the right method for right women remains both an art and science, because many a times we are not able to proper drug which should be given to the patient. That is very important. So let us explore that through expert insight and real life scenarios. So I'm your moderator, and we have our worthy experts, Dr. Ranjana Joshi from Jamshedpur, Dr. Ranjana Jha from Katihar, and we have our panelist, Dr. Archana Jha. I don't know whether she has joined or not. Dr. Maushami Das Ghosh, I saw she is there. Dr. Imrana Rahman, Dr. Rajshri Purve, Dr. Kavita Barnwal, Dr. Rita Thakur, Dr. Swati Singhal, Dr. Khushbu from Purnia. Dr. Amrita is not able to join. So once again, I would like to welcome everybody. And now, so if you see the modern contraceptive method mix in India, these are the methods like we all know: lactational amenorrhea, tubal ligation, vasectomy, male condom, OCs, injectables, intrauterine device. But lot is still missing, like non-hormonal contraceptives, implants, female condoms, and other natural methods, and many more. So let us begin our first question from Dr. Rita Thakur. Dr. Rita is there? Hello? Yes, ma'am. Yeah. So because I am not able to see anyone. So anyway, okay. So this is for you. How do you individualize contraceptive choices in clinical practice?
Ma'am, that will depend upon the person's, because this is a cafeteria choice. So the person must consider, we must consider the safety, efficacy of the device, the availability of the device, the affordability of the patient, whether the patient can get the access of the device easily, or whether it is suiting with the lifestyle of the patient or not. And this is the way we choose the contraception, and the choice of the patient is of paramount importance.
How are you going to choose it? What did you say? Age parity you will be saying, no? At least. Hello?
Yes, of course, ma'am. Her age, medical eligibility criteria should be there.
Okay.
For that, we have a checklist.
Okay.
And then we'll proceed further.
So, how much weight do you give to a patient's preference versus medical eligibility? Do you think that... Yeah, tell me.
The choice of contraception is very autonomous to the patient, ma'am. But the clinical evidences are there, and then should be taken into account to get a safe medical eligibility for the patient.
So that is very important, that medical eligibility is non-negotiable. So safety comes first, and you have to counsel your patient properly that this method is best for you. So she should take that. Because what we see that the best contraceptive method is not the most effective one on paper, but the one the women understand and accept and continue using it. That is very important. Okay. So these are the comparative effectiveness of the different methods, like less effective withdrawals, spermicides, male condom, all these are less effective, where the most effective one is permanent method, that is vasectomy and female sterilization, and the LARC method like implants and IUD. So they are the most effective methods. And with this is the categorizing the contraceptive methods, which include reversible and non-reversible contraceptions like short-acting, long-acting, reversible, and the barrier method, whereas non-reversible, we all know, it is female and male sterilization. Now, next question goes to, what are different oral contraceptive pills, Dr. Khushbu?
So basically different oral contraceptive pills like we have combined estrogen and progesterone containing pills. Then we do have only progesterone only pills available. And if we divide on the basis of hormone composition, so we do have monophasic, biphasic, and triphasic pills in which the dosage changes as per the cycle length. And also we can divide it as per the generation. So we have 4 generation, first generation,
Okay,
second,
that will
third.
go later. I want just a broader classification.
Yeah.
Are there any non-hormonal OC pills also available?
So non-hormonal is Saheli centchromine available for us.
We live in India, so I think we should discuss about this also. This is important. Yeah. Okay. Anything else you want to add?
So also emergency containing contraceptive pills, emergency pills are also available. So these are like different choices available for us.
So in a broader classification, we can say combined pills, progesterone only pills, and emergency pills are also can be used.
Yeah.
And the non-hormonal you can go for centromines. So Dr. Rashi Purve is there. What is the mechanism of action of combined OC pills? I think if she's not there, then Khushbu, you can take this.
So basically combined hormonal pills, they inhibit the ovulation. They suppress the ovulation. In addition to that, they also make the thickening of cervical mucus, which will basically hamper the migration of sperm. And sometimes some pills can also delay the ovulation. So these are
thinning
like
of the
broader,
endometrium. Also thinning of the endometrium. As endometrium gets thin, so it also prevents pregnancy. Yeah.
So mainly it provides triple protection. That is no ovulation, no sperm entry, and no implantation. So that is the beauty of this oral contraceptive pills. Okay. Dr. Imrana?
Yeah,
Dr. Imrana is there?
Yes, yes.
So this is for you. What is the effectiveness of oral contraceptive pills?
Actually, there are
how will you
effectiveness
differentiate
depends
it?
upon how perfectly the patient is using the pill, the real-time effectiveness and the theoretical effectiveness.
Okay.
So the OCP effectiveness is, you need to counsel. The failure rate is most important for counseling. If it is perfectly taken correctly every day, the failure rate is 0.3% per year. That is 99.7% effective. If typically real world, if we consider, then the failure rate is 7 to 9% per year. That is 91 to 93% effective. The gap is mainly due to missed pill, vomiting, diarrhea, late intake, drug interactions if she is on ATT, which are the enzyme inducers, anti-epileptics. The POPs, progesterone only pills, are very time sensitive, has to be taken on the same time of the day. And factors that reduce effectiveness are missing pills by more than 2 days, vomiting, diarrhea, enzyme inducing, and starting the pack late, and poor adherence, poor compliance as usually. So counseling forms most critical part and most important so far as the effectiveness of this OCP is concerned. OCP typical use effectiveness is 91 to 93% and 99.7% if there is no if the compliance is very nice. For implant also okay, only for OCP.
What about emergency contraception? Do you think that emergency contraceptions are also the contraceptive? I mean, you should include it in
No,
the
no,
contraception.
not at all. It should never be used again and again, and we should
It should be
also
kept as a backup, I think.
dissuade our patients and say no to that, because usually they do that the similar way, and they take multiple times the emergency contraceptive.
So very nicely you have said, and we know all that what are the combined oral contraceptives which contain estrogen and progesterone, and they form this. Now, Dr. Mosmi, what are the different regimes for COCs? A broader regime I just want to know, because we'll be covering more than that. Dr. Dr. Mosmi. Yeah.
Yes, madam. Good evening. Good evening, everybody.
Good evening.
Yeah. So to classify broadly, we can most commonly it is 21/7 regime. Where there are 21 active tablets and 7 placebo tablets. The other can be 24/4, that is 24 active tablets and 4 placebo tablets. And the third way is the extended regime, where the pills are given in a continuous manner up to 84 days. And that means the patient will have a 3-month cycle. So these are the most common methods followed in our country: 21/7, 24/4, and extended.
And what about continuous one? Can you give
it? Yes, continuous we can give, especially in case of endometriosis or in case of symptomatic, but that again, it has to be properly indicated and where it is medically appropriate.
Okay. Do you want to tell about the evolution of combined oral pills, how it started? Can you include? So normally if you see the evolution, it started in 1960s, and mainly later on it became safer, smarter, and more patient friendly over time. In 1960s, it was a big thing, and it has a high doses of estrogen formulation. So it had a lot of side effects. So in 1970s, again, the safety concern was the most, and the mini pills came into existence. In 1980, refinement phase came, where attempt to mimic natural hormonal cycles, and here came the non-contraceptive health benefits of these OC pills. After this, in 1990, the low-dose pills came, which was a major breakthrough, and same efficacy with fewer side effects. So that was the best thing which has happened. And finally, in 2010, precision and personalization, that is use of the natural estrogen, development of advanced progestin, and the research on genetic and personalized child rate. So we have moving towards the individualized contraception and better metabolic safety. So this way, the evolution of combined OC pills have been done. Now, what are the generations of COCs?
Yeah, thank you. Thank you, Pratibadi, for the opportunity. So, since it was discovered in May 1960 and continuously evaluation took place, so basically generations were described according to the type of the progesterone that is being used. So, these progesterones are mostly progestational, 19 odd testosterone derivatives, and they have many actions like androgenic, antiestrogenic, anabolic, progestational. So depending on the type of the progesterone, because ethinyl estradiol is the same in all the 4 generations, only the amount of ethinyl estradiol is being declined, but the type of progesterone is being changed. So first generation contains norethindrone acetate, ethinyl diacetate, and norethindrone. It's not very common nowadays. Second generation uses levonorgestrel and norgestrel. They have fewer risk of blood clots. So these are popularly used like Maladi, Mala N. And third generation OCPs that contain desogestrel, gestodin, and norgestimate, they have less androgenic activity, but there are more chances of venous thromboembolism. So this is very popular nowadays. And fourth generation that includes drospirenone. That is basically spironolone analog. There are other molecules also like non-megestrol, danogest, chloramadinone, but most common that is being used is drospirenone, and is available in the form of yasmin that is very commonly used. So depending on the type of the progesterone, the generation of OCPs has been described. And low COC that contains less than 35 microgram ethinyl estradiol. So with increasing generation, endogenic effects is being reduced, side effects are being reduced, and better quality of even the low dose of estrogen is also being decreased.
Very nicely you have summarized this, that because what we want, safety and the patient's acceptance, that can be with this fourth generation or the low dose COCs. So you can see that the now high doses, which already she has told. What about the estrogen in COCs?
Estrogen actually.
We have now.
Someone else?
Yeah, anybody can talk.
Yeah. So estrogen was actually estradiol is being basically is a prime component, and other estrogens like mestranol not very commonly used. And this estradiol was earlier in the higher dose, but nowadays it's very low dose, like less than 35, even 20 microgram of estradiol is being used, and that is preferred
moderate
because
dose
the
is used for
chances
the
of
fecal control. Yeah. Okay.
Yeah, moderate dose in 30-35 that is used for mostly contraception process.
Okay.
But low dose OC pills are being used mostly in cases of PCOS to prevent other features like acne and everything.
Pratibha?
Yeah, yes. Who's speaking? Yeah.
Pratibha.
Okay, yes. Yeah, you want to say something? Yes.
Yeah, I'd like to mention that we now have the latest estetrol, the latest low-dose estrogen, which has come into the picture. And this is it is manufactured from the fetal liver, natural estrogen. It has been approved in USA and UK and Europe. And this has the biggest advantages, as you know, better metabolic profile.
Yes. So this newer
Estetrol.
formulation.
Estetrol.
It has not come to our country. It will take time.
Estradiol you are talking, no?
Yeah.
Estradiol she is talking.
Yeah, estetrol. 4 mg.
Yeah. So they are more physiological estrogens. Okay.
Even cyproterone acetate is used in many OC pills that has got a good effect in PCOS.
Okay. Now, why there has been shift from towards the low dose estrogen pill? This is just I want to ask.
Good evening, ma'am. Thank you for
Good
the
evening.
opportunity. Actually, safety is the main concern, and patient tolerability is the driving force. Safety regarding the blood clots, venous thromboembolic phenomena, it reduced with low dose estrogen OCT, especially between 20 to 35 microgram. Initially, and more than that, and there is a high risk of VTE, and now with low dose, the risk reduced by 50%. And cardiovascular risk, especially smokers and 35 years old women, the risk is very less with the low dose estrogen. And estrogenic side effects like mood, breast tenderness is also an important factor. And regarding the tolerance of patient is more comfortable because the like nausea, vomiting, compliance is very good.
Yeah.
And
So it is not only the safety factor, but also the compliance of the also plays an important role.
This is also very important. And acne whether are less with the low dose pills.
So this is what they've said, that the why use low dose pills, because high dose of estrogen can cause side effects, will result into discontinuation of OC pills and switching to the less effective methods, and may result into unintended pregnancies. So thus substituting a therapeutically equivalent low dose OC pills can have significant clinical and economic effect on individuals and public health, thereby decreasing this unintended pregnancies. Nowadays, we are more focusing that they should, once the patient has started taking, or the female has started taking contraception, she should continue taking it. She should not just stop it because she is not able to take and may result into unintended pregnancies. That should be stopped. So that is why there is a shift for the safety and tolerability, and this will give a balance, efficacy versus risk. Now, Dr. Amrita, she's not there, so anybody can take this question. That what are the advantages of CCO beyond contraception in the perimenopausal? I think.
Yeah. Should I take? So there are so many advantages.
In the perimenopausal women, okay, most of them suffer from the dysfunctional uterine bleeding, and we are having so many natural estrogen combined pills like Clara, which are much physiological, which mimic the physiology of the menstruation, and with a dynamic combination of valerate and dinogest.
What are the advantages?
Advantages are beyond contraception is the cycle control, the bleeding, excessive bleeding which anybody might have, and sometimes they will also run due to the shedding of the endometrium, and there will be a lot of endometrial thinning, so that will be also supported, and the good cycle control will be there. Secondly, in the gynecological condition of endometriosis, there will be suppression of the endometrium. Dysmenorrhea is very common in this particular age group, and reduction of endometrial, ovarian, and these cancers, colorectal cancers. Improvement in the ovarian cyst will go off if it is there. Benign breast disease protection is there. So all these things. So we have a panorama of the benefits.
And along with the androgenic factors also, like acne and hirsutism,
and that will
be
also
taken
go.
care of it. Okay.
Improvement of bone density and all.
Yeah.
Cardioprotective.
So these are the health benefits of oral contraceptives. We all know. I'm not going in details about this. And now, Dr. Archana, I don't know whether she is, but she's there. Dr. Archana is there. I think she's not there. So Dr. Kavita, you can take this, or anybody can take this question.
Yeah. Drospirenone is actually spironolactone analog, and that is fourth generation progesterone. Is being used in a fourth generation OC pills. So it has got very good effects. It has least androgenic effect, and it also prevents water retention, bloating. So this combination, drospirenone and ethinyl estradiol, is nowadays very commonly used, especially in younger age group girls. So because there is more progesterogenic effect, androgenic effect, and anti-mineralocorticoid effect, as well as anti-adipogenic effects. So all are present in drospirenone, and it's spironolactone analog. That's why it also prevents water retention, and so it's very commonly used in young age.
Okay. So it has all these four properties, that is progesterogenic, anti-androgenic, anti-mineralocorticoid, and anti-adipogenic. So really reduces weight also. Now, so can you tell me which regime you will prefer, 24/4 or 21/7? Yeah, anybody?
24/4 regimen is better because of the less pill burden and better control of the cycle, and hormonal exposure is 24 days, and we have 4 placebo tablets. Here in 21/7 there are 7 placebo tablets. Sometimes the patient, if misses the pill, may lead to ovulation in 21/7 regimen. And ovulation control might not be there if one pill is even missed. And better ovarian function is there in 24/4, better inhibition of the follicle. So it is always better to go for a 24/4 regimen.
Okay. So they have a better ovarian suppression, less hormonal withdrawal symptoms, and improved cycle control. So that is why 24/4 is more preferred. Anyway, what are the key limitations of contraceptive method mix in India? Dr. Rashi Pulve is there. Otherwise, Swati, if you are there, anybody can take question. Swati is there? Or because I am not able to see any faces. So that is why I'm not able to know.
There are many limitations in contraceptive method mix in India because due to lack of awareness, proper supply, patients are more prone to go to sterilization, like in rural population, but in they prefer sterilization rather than going for temporary method because of lack of awareness, lack of utilization, lack of supply, and the chain is not maintained. And when we are giving, and they are very much concerned about the safety. These all are associated with the care education difference, their awareness difference. So the over sterilization, and there are less of that male factor. Contraceptives are less. That's a key limitation factor in contraceptive method.
Okay. So we need for expanding contraceptive basket now. and expanding awareness is the need of an hour. So that is very important, because still many people, they don't know the importance of implants and non-hormonal methods which are available. So that should also all should be popularized among our female clients. Now,
Centroman is a selective estrogen receptor modulator SERM with two main clinical uses. One is the contraception, which is not that strong, and second is the treatment of dysfunctional uterine bleeding. Typical contraceptive use effectiveness, if we use it at a proper adherence and compliance, and 92 to 95% protection is there, and perfect use, if perfect use, 98 to 99%, and if it is real time, and sometimes if the pill is missed, then 92 to 95%. And the failure rate is 1 to 2 pregnancies per 1,000 women per year. And how does it act? It acts by delaying the ovum transport and of altering the endometrial receptivity, that is by preventing implantation. It does not consistently inhibit ovulation, and needs strict adherence, but sometimes because of the kind of the protocol which we need to advise is every 4 days, and start on the day 1 of the ormeloxifin. That is, sometimes a patient might not find it like a pill, it is something like a medicine. So that can be one of the
challenges for this.
Yeah, challenge for this.
Okay. So that is why it is perceived as less effective, and though efficacy is reasonable, but limited promotion and compared to other methods. Normally, it is not being promoted very well, but in, I think, health sectors, it is in the government health sectors, it is being seen. That is why I wanted to ask this question.
Yeah, it is wonderful so far as
But
bleeding
it's
control
wonderful,
is
especially in
concerned.
lactating mothers. When the women cannot take OC pills, even they are not taking mini progesterone pills, then we can give or meloxifene, and it has good effect. Even in menorrhagia, it's very much effective. What I have seen
Menorrhagia,
in
for
my cases,
menorrhagia, it
it's
is
very useful in
wonderful.
cases of menorrhagia also.
I think side effects are also lesser in this.
Very less, very
Side
Yeah,
less.
effects are
very
not.
Especially
less.
for
Even
diabetic
then,
Patient
no
doesn't
side effects.
complain
patient.
at
And
all.
the unique thing is that it is Indian option. We have,
Yeah.
it has been developed in India, so I think we should promote it. If the patient, if it is not going and doing any harm, it should be promoted, I think.
One submission.
Yes,
It
madam.
can be
Yes.
what I do generally is sometimes I combine
Imrana,
it.
madam wants to say something. Dr.
Oh,
Sheila
sorry,
Mani.
No
sorry.
problem. Regarding Centroman,
yes, ma'am.
Yes, some patients who are on a longer use can develop retention cyst in ovary.
Okay.
Because they're going for amenorrhea, so that follicular growth and arrest.
Okay.
And one is longer term, if they have used, there is an incidence of 7% patient can develop hyperplasia of endometrium. So if we are using in a perimenopausal age group, we'll have to be little bit careful or look at the endometrium. Okay. And as AUB, it is very helpful. Even in fact, in adolescents, instead of 60, we can use 30.
Okay.
Yes.
30 mg twice a week, because they come with puberty menorrhagia and it is non-hormonal. Because if they're very young, we can't give them estrogens.
Yes.
Okay. After 16 years only, we can give. So before that and now early menarche is a problem. So 30 mg twice a week for 3 weeks and then once a week. So for puberty menorrhagia also it is a good option.
I think availability is a very big issue.
No, not at all.
No, it's easily available in our part.
A lot of
It's
brands
easily
available.
available in the name of Saheli.
It's a Haley.
In our part, it's available in the form Saheli.
Sevista is the research. Sevista is the brand.
Sevista is available, but
Sevista is available.
No, Saheli is available
Saheli is
in the government
sector.
I also give in the adolescent group, and it acts wonderfully.
Okay. So now, what are the major risks associated with COCs and how should you avoid it? Dr. Rita?
Rita?
Yes, madam. Yes, madam.
Yeah.
What are the major risks associated with COCs and where you should avoid it? The major risk of COCs are, ma'am, generally increased cholesterol level in the body. So we shouldn't give in the smoking patients who are at the risk of cardiac or any stroke, above 35 years and smokers, history of thrombosis, we shouldn't give in those patients COCs. This comes under the category 4 risk, where the shouldn't give it with those patients.
Voice is not clear actually.
Voice is not clear.
I'm not able to listen. Yeah.
But I have unmuted, ma'am.
Yeah. Okay. So you said no risk and there you.
Yes. I said, ma'am, this shouldn't be given in the patients who are at the high risk of thrombosis, venous
Yeah, we all know this.
embolism.
That is very important, but this should always be kept in mind. And I think more than us, patient will tell us that, madam, isko main lena chahiye ki nahi lena chahiye. Anyway, now next question is for Dr. Mosby. And this is a case. It is 19-year-old unmarried diagnosed PCO with BMI 28 kg per meter square. She has irregular cycles. She is sexually active, using condom for contraception. And she also complained of increased facial hair growth and acne on her face. Now she has two questions in her mind: how best you can treat this condition, and what is the best contraception? So we'll take one by one. Now, Dr. Mosmi, how can you best treat this condition?
Yes, madam. Yes. So she is an obese PCOS.
Yes.
Who is sexually active. So we have to address that she has irregular cycles. So we have to address her menstrual problem. Also contraception.
What first step you will take to her? She is obese.
So obese. First will be lifestyle modification. Where she'll be advised for exercise and like dietary modification in the form of like avoid junk food and having a right BMI. So that has to be.
Okay. So first is lifestyle modification is very important. That is the foundation for PCOS patients. So you should be always advising that. Then
yes. So counseling here goes a very long way, because even she has to be told that weight reduction will help her. Then secondly, for her menstrual problems, she can be treated like for her temporary things like suppose excess facial hair growth and acne. She can be advised for the hair removal small things in the short term, and for long term, she can be given oral contraceptive pills, because this will take care of her menstrual problems as well as it will help her in contraception. So ideally, in this case, we can give her third or fourth generation pills, which will have less androgenic side effects. Okay. So either drospirenone, Dynogest, or even cyproterone acetate will be good in this case.
Okay. Cyproterone acetate you will give to this patient. Will you give cyproterone acetate to this patient?
Many times. No,
this patient, she needs contraception also.
Contraception also. You don't have to drospirenone.
Drospirenone is the best for her. And any additional options if needed?
Minoxidil has got good effect. So I think, and also metformin for women.
So
BMI is high, then we can give metformin. As well as minoxidil combination. And they are good options in this case.
So mainly metformin and anti-androgen if severe hirsutism is there after contraception is ensured. And cosmetic measures, she can go for this laser, dermatology and support. I mean, she can go for those also.
Even thin hydrochloride cream is also effective in cases of
so you should focus on dual benefits, that is contraception plus treatment for acne, hirsutism and cycle regulation. That is the three things you should keep in mind. So best contraception, you have already said that this is COC. Okay. Dr. Mosmi.
Yes, madam. Yes.
Okay.
So for these young girls, so counseling has to be very. They will have a lot of queries. So these girls need time for proper counseling. Only then there will be like adherence to the treatment.
So COCs are the best, and we know what is the why it should be given. Can you please give any other options to her? Can you think of any other option giving to her? This particular girl.
Mirena?
No. CC married. CC married?
No, but she's sexually active.
So
See,
she's sexually active.
So
Yeah, we
normally,
can give her, but
do you
I think
can you
still
advise her only condoms, that she should continue with the condoms? No, that is less effective. POPs,
Yeah.
POPs can be advised to her.
yeah, we can
Yes.
give POP also.
Time,
Yes,
Yes.
yes.
time.
But again,
Progesterone, yes.
she has एंटी एंड्रोजेनिक इफेक्ट कहाँ से आएगा उसके लिए?
तो फिर उसको सेप्रेटेरन देना पड़ेगा ना, ट्रोस्पिरेनॉन के साथ, या तो
नहीं, but
Drospirenone is mandatory for her because
normally
of the
what is said that there is no other option ideal for her. She should be taking these Fogsi pills because that is the best option for her. That will prevent her disease and also prevent her pregnancy. So that way you have to counsel this patient properly. So this is what we have just talked. Now, this is the slide which explains the treatment option for PCOS related menstrual dysfunction, focusing on the mechanism of action and clinical outcomes. We have just said this. Combined pills, what they do, they mainly causes the decrease in GnRH frequency, decrease in LH and FSH, and increase in sex hormone binding globulin, and decrease in androgen-free testosterone, and also causes endometrial stabilization. So the advantage is that it is a first line for cycle control, hyperandrogenism, but again, metabolic control is not very good with this. So you have to outweigh and the risk for that. Second is androgen blockers, that is all the spironolactone or the flutamide. So here again, the mechanism of action is that it decreases the androgen action and increases the insulin sensitivity. So it is best for hirsutism, acne, but mostly but it must be combined with contraception because it does not give contraceptive benefits. And third is your lifestyle modification. So with COCs, it controls cycle control and androgen suppression, whereas with anti-androgen, cosmetic symptoms, but you have to add contraception in these patients. And finally, the lifestyle modification and insulin sensitizer that should be added. This is the same thing which we have learned. Now, so this I was asking. In this patient, can you give sapropterin acetate? We have just discussed.
Yes.
Yes. You
It
can
is
give sapropterin
androgenic.
acetate. You can give sapropterin
Anti-androgenic.
No, this patient. Acha, you can give. So how will you protect her pregnancy?
Yeah, that is another issue. So either we can give a combination of sapropterin acetate with ethinyl estradiol. Many drugs are coming with sapropterin acetate, ethinyl estradiol, drospirenone. So that we can give.
So
Combination
normally,
of sapropterin and ethinyl estradiol, that is better option in this case.
Sure. Okay. Now, Dr. Imrana, what are the potential risks of thrombosis for
So
COC?
pills, this is due to the estrogen-driven changes in the coagulation and the estrogen component of the OC pill. So these are the types of the thrombosis will be a venous thromboembolism, and or it can be an arterial, which is more dangerous. And thrombophilia cannot be screening is not routinely recommended. Because the estrogen increases the clotting factors 2, 7, 10, 8 and fibrinogen, and decreases the natural anticoagulants which are present in our body, that is protein C and activated protein C resistant protein S, and so the next effect is the hypercoagulable state. So on combined dose pill, the absolute risk, which is very important to be counseled to the patient, is around 3 to 9 per 10,000. However, it is lesser than the pregnancy, which is 5 to 9, and that of the postpartum, which is 40 to 60 per 10,000 women. But it is to be counseled that this is the thrombosis risk. So it's very important in OPD screening. We have to consider the age of the patient, the BMI of the patient. If it is more than 35, BMI more than 30, she's a smoker, or any personal history is very, very important, because personal history of venous thromboembolism, a family history of thrombosis, especially if it is under the age of 50 years, and if she is having a known thrombophilia. However, in Indian perspective, we don't offer a thrombophilia screen routinely, but somehow if the person, depending on the case, she has already suffered someone a stroke or a cerebral or anything like that have happened in the family, and she would have gone for a thrombophilias screen in that particular case, then factor V lesion or any protein CS deficiency or prolonged immobilization, issues in postpartum. So not all pills carry the same risk. Third generation progestin, that is desogestrel and gestudin and drospirenone, they have a higher risk.
Better, huh?
It is the lowest with the levonorgestrel containing pill. So
But do you think that the screening should be done in all the patients? Like,
no, not at all, because of the poor yield, and it is very not cost effective, and not significantly will be finding any not recommended by American College, not recommended by Indian Society, not recommended by WHO, and false reassurance, because negative test does not mean a zero
means,
risk,
yes, that is
and
very
positive,
important. Yeah.
yeah, and positive
Family
test
history should be taken. Yeah,
I think
history
may
of
family
cause
previous.
history.
change of
Yeah.
management in low risk
It's very
individuals.
important.
So women with the family history of
History is
ETD is
most
the first
yeah,
important.
that
history
is very,
relative.
history is very important.
Yeah.
And it
That gives a
outweighs
hint.
the
Huh.
lab test. It outweighs the lab test, even if she is positive. So personal history of if she's having a thrombophilia or VTE, the first degree relative having a
first
VTE, and
negative
these are
and
very important.
negative
This
screening
thing.
also does not exclude all type of thrombophilias. That is
Yeah,
also you
so
must keep
that
it.
is it. So it is only reserved, the screening, for patient with personal or family history of thromboembolism. So that is very important.
And just like that, what about POPs?
That will be preferred.
OP does not have VT risks. So we can give.
Yeah, POPs can be well given.
They are
Progestogen
the
only
ones
pills or
in
less
VTE case.
estrogen.
Huh.
Now, Dr. Khushbu?
Levonorgestrel is safe, and
Yeah.
in those we can go for if the patient is on a higher age side, or then we can go for Mirenanon. Does not carry in thrombosis risk and all, IUCD. These are POP important.
Dr. Khushbu?
So drospirenone and ethynyl estradiol definitely has
For
got
hirsutism.
because drospirenone is a potent anti-androgenic progestin. So it will basically block the androgen production, and it will also reduces the free available testosterone. So it will definitely have improvement in hirsutism, but it does take time, like 3 to 6 months should be given for the clinical improvement, and some women might need like 6 to 12 months for improvement.
Yes.
Even if after the treatment, if they doesn't have improvement, we can still add like finasteride or cyproterone acetate.
So normally this slide
And
just
it
shows
also decreases the like Ferriman Galvis score, also it decrease overall, reduces the hirsutism.
Now, what about the cycle control? That effect of drospirenone, 3
So it has
milligram and this.
It has got good cycle control. It also decreases the breakthrough bleeding, and one can achieve proper 28 day cycle because proper withdrawal will be there. So they can have a reduction in intermenstrual bleeding. It will also decrease the prostaglandin production. So it will have a good pain relief as well, and cycle control will be there.
Okay. Okay. Now, Dr. Kavita,
Yes.
32-year-old women with chronic pelvic
Yes.
pain and dysmenorrhea, diagnosed endometriosis and not planning pregnancy. Now, what is the role of COCs in endometriosis? And which
Definitely she's not planning for pregnancy, so COC should be first choice. And because this OCPs prevent ovulation, thereby they suppress estrogen production. And since estrogen is the main culprit in cases of endometriosis, so it helps in preventing all sorts of lesions, also prevents pain in all sorts, because it causes atrophy of the prostaglandin production, reduces inflammatory cytokine, so helpful in preventing pain in all sorts like dysmenorrhea, dyspareunia, dysphagia. Every pain is suppressed, and also the lesions are also reduced wherever the ectopic endometrial tissue is present. The lesions are also reduced. So it helps COC, very good choice in cases of endometriosis when especially
how
she is
long
not
you can
planning for
give?
pregnancy, and it
How
can
long
be
you
given.
can give?
Yeah, it can be given it can be given if there is no any history of contraindication, like she's not smoking, she's not having any history of thromboembolism, she
For how long you
her
can give?
BMI is also not very high. Then
How
you can
many
give
days?
for long term, even for 1 year. 1 year we can give, we can give it for 1 year. And regimen, I think, is best regimen is either we can give continuous regimen
It is for
where
2
no
years, up to 2
placebo.
years you can give this.
Yeah, we can give it. Yeah. So actually, the patient doesn't want for long. Even patient comes के नहीं अब इतना ज़्यादा दे दिए अब दूसरा दवा दीजिए. But still, we can give it easily for safely for 1 or 2 years. And so this is extended regime. That is better, but we can give more days without placebo. Like we can use 84 days regime, where 84 days pills are given, low dose pills, and we will have a break, or we can give it continuously for 1 year. But women sometimes want menstruation, so that's why we can give this extended regime where we prescribe for longer duration, like 84 days, and we can give placebo for 1 week, and then she will have smaller amount of bleeding, less pain. So this regimen is better. And if the woman is happy with amenorrhea, then we can give it continuously also for 1 year.
Yes, so mainly translate the physiology into relief. That
Can
is
I
fewer
come in?
periods,
Can I
less
come in,
pain.
Pratibha? Yeah.
Yes, madam.
Yeah. So now the recent theories where we are talking about endometriosis. Okay.
Yes.
So yes, definitely the lower dose estrogen we have to give, not the high. Okay.
Correct.
Because
Correct.
basically what we want in endometriosis, we want to lower the level of estrogen.
Yes.
Yeah. And what happens in endometriosis, that utopic endometrium, which is there in the endometriotic implants, also produces estrogen on its own. And that has an inflammatory action, and that causes pain. Okay. So basically it is the estrogen. So now the recent theory is that we have to suppress the estrogen. And that is why we started giving GnRH, right?
Correct.
Yeah. So
That
for
is
extensive
another,
endometriosis, OC pills will not work. Anyway, for young girls with very mild, yes, okay, it works. But for a moderate to severe endometriosis, estrogen will not be the choice. I mean, here I'm not discussing about that.
That will be
And now we have
Madam, actually, here we have to use
agonist or antagonist. And now we have antagonist.
Antagonist.
And antagonist
There is
reduces
agonist,
the level of
both are being
estrogen
used.
further.
Yeah.
So for moderate to severe now, mild, yes, OC pill. But moderate to severe now, we'll have to give, now we used to give GnRH agonist, now we have antagonist. Because agonist will have again a flare-up action, and antagonist...
So mild, madam,
better drug.
moderate
Antagonist
to
has got
severe
good. Even it's oral drug, and it's
Oral
available
only.
150
Yeah,
to
Ilagola.
200 milligram,
Ilagola.
and it's very good. Madam, in clinical practice, we use these drugs only. So you see, we give
No,
only
no.
for
For
Saturday.
discussion, I just added one point. That this is for milder forms.
Yes.
Ilagolix is only for better for the control of the
Adenomyosis.
pain, and no, it's for the pain control. It's a secondary therapy, and it cannot be used for pretty long period of time, considering the side effects like bone loss and hair loss. Moreover, a patient with a moderate and severe endometriosis will never land up in pregnancy. So as such, she is fighting, and most of the times they come with the complaints of getting pregnant. So, and estrogen is not recommended for them. We need to consider other options like Mirena for them, rather than going for a prolonged
No,
dosing.
for pain relief.
For adenomyosis, Mirena is better choice.
I think
will not help.
For
Marina,
adenomyosis, it will help. Mirena will help, but for
okay.
chocolate cyst or other endometriotic lesions, Mirena is not helpful.
Mirena is
It's
not
helpful
going to
only in
help.
adenomyosis. Yeah. GnRH agonists or antagonists are definitely better than OCPs.
single dose monotherapy 150. Within 4 weeks, it will bring down the pain. Now, there is another Ecnine 200 mg BD where there is a more chance of bone resorption, but not with monotherapy. Monotherapy can go on for a longer period. Okay? Yeah. Okay. I think we should proceed with all.
Yeah. Dr. Swati, this is for you. A 27-year-old woman present with severe mood swings, irritability, anxiety, bloating occurring in the luteal phase, affecting work and relationship.
Yeah,
Symptoms. Okay, you have.
As per the case, severe mood swing, irritability, anxiety, bloating, and her work and relationship is all affected. And the catch is the symptom resolve after menstruation. This patient comes under the case of PMDD, that is premenstrual dysphoric disorder. And this is a severe form of premenstrual syndrome. And here we need a holistic approach in this type of patient.
How will you differentiate that is from the premenstrual symptoms? Yeah.
There are symptoms like premenstrual symptom is a minor form, and PMDD is the severe form. In PMSs, the symptoms are like headache, vomiting, bloating, premenstrual period, and the core symptoms like mood swings and all these are less severe. And usually, patients see these two in two cycles. But in PMDD, all these symptoms in all the cycles, on her daily day activity has reduced.
How will you diagnose that this is PMDD? What is there any criteria?
There are 4-5 criteria like symptoms, the core symptoms like mood symptoms. If it have more than 5 or equal to 5 symptoms and one core symptom there, and the patient usually present with the symptoms of depression, showing the signs of suicidal tendency, and these symptoms are seen in all cycles in premenstrual period. Then it comes to PMDD, and this is the serious form, and these patients need proper counseling and treatment. In form
So that is more than 5 symptoms, including one effective symptom. That is PMDD, and usually it get relieved after menses. So that is
the core picture of that. And the treatment, as we say, you need holistic approach. Like lifestyle modification in form of exercise, diet, stress reduction, calcium supplement, but many a time it is insufficient. The first therapy in these cases are SSRI, fluoxetine in low doses for 6 cycles. And if these are concerned about contraception, then drospirenone containing pills, combined pills, are recommended in these type of patients because it has anti-androgenic property, anti-mineral property that helps. And in refractory cases where all these two treatment are failed, then we go GnRS agonist treatment, but the thing is bone mineral density.
Okay. So this is the key point, that this is the first line therapy. First line treatment is the SSRI, and the second line treatment is the oral contraceptive, depending upon the severity of the problem.
Disease.
So basically, PMDD is not a hormonal axis disorder, but it is an abnormal response to the normal hormonal fluctuations. So that is what we have to understand. It is a neurohormonal sensitivity disorder, and the treatment basically target both serotonin and ovulation suppression. With this, patient will get a relief. Now, Dr. Khushbu?
So 42-year-old perimenopausal contraindications to hormone.
So can COCs be used in this age group and benefits?
So basically, like 42 years, can we use COC? The answer is yes, we can use COC at this age group, provided she does
what
not
is the
have any.
COCs in this patient? Again,
so low dose combined estrogen and
We will give
containing
low dose
contraception.
in this case because
So
of
they
lesser
are
side effects and better tolerability.
And but provided we have to rule out certain contraindications like hypertension, previous episode of venous thromboembolism, migraine with aura, and she should be like non-smoker. So all these contraindications should be ruled out before prescribing her COCs at this age group. And preferred option is definitely
benefits for this.
Benefit, it will have a good cycle control, it will have a good relief from dysmenorrhea, it will reduce the intermenstrual bleeding as well. Regarding the preferred option, so around 42 years, we should see the woman as a whole. Like maybe if she has got heavy menstrual bleeding, So definitely at that point of time, Mirena will be the preferred option as
Yes.
compared to COC.
Yeah.
If she has got like hirsutism or PCO, so that time we will prefer the COC containing drosperinone or any other potent anti-androgenic. So
Okay.
like choice will differ.
Choice will depend, yes. Will depend upon. What about the COCs?
Yeah.
Ovarian
Yeah,
cancer?
it has got definitely reduces the risk of ovarian cancer. There was a scientist, Casa Granda, who has studied that he found in less than number of years women is ovulating, having ovulation suppressed. So this will indicate the risk of ovarian cancer. So definitely the woman is taking for longer durations of ovarian cancer. So their studies have some different connection, but different percent. If the woman is taking and it can be real tumor of the ovary, and this is most common ovarian cancer, if the cancer.
Okay.
So
Maybe
it can
epithelial
be given for a long duration, and it also reduces the risk in cases of BRCA1 and BRCA2 gene positive.
Yes. Swati, about the endometrial cancer?
Yeah,
It also reduces section in the endometrial cancer.
Swati,
It
yeah.
also reduces the chances endometrial cancer. Even according to study, if the patient uses more than the chances of reduction is relieved for more than 10 years, even after the stopping of that pills. And it is said that there is 50% reduction for endometrial cancer in user versus non-user. And COC with cholesterol potential is more effective and low fusion active, more effective in reducing the endometrial
So yeah,
cancer.
higher progesterogenic potency. Now, Mosmi, can you tell Dr. Paushmi regarding the this colorectal cancers? Anybody can take, if she's there, Dr. Mosmi is there, or our experts can answer this. Dr. Ranjana Jha. Ranjana is there. Mosmi, Rasma, nobody is there. Imrana, you speak then.
Yeah, all studies have shown that the chances of endometrial colorectal cancer are reduced.
Cancer, there was a comparison with the never used somebody who has never used ocipil in their lifetime, and with the use of ocipil there was a significant impact, and there was a decrease in the incidence of the colorectal and endometrial cancer. However, we need to weigh it against the risk of elevated risk of the breast cancer.
Yes.
So
yeah, I think this endometrial, ovarian, colorectal cancer, they all are belonging to Lynch syndrome. So I think by decreasing any, they are very closely associated in like a family. So if the chances of ovarian cancer is decreased, definitely endometrial cancer will also be reduced because there is atrophy or thinning of the endometrium with estrogen progesterone, and also the chances of colorectal cancer will be less.
Okay. Experts, you want to say something? Dr. Ranjana Jha, anything you want to add? If she's there. Now, anybody can answer. I think Dr. Rashid Gurve is not there. What are the benefits and side effects of COCs? We all have been discussing in between, but if you can enumerate different, yeah.
Correction of anemia if the woman is menstruating heavily.
First is,
cycle control,
yeah.
preventing pregnancy, yeah, improves bone health, prevents ovarian cancer, endometrial cancer. Also, by preventing unwanted pregnancy, reduces maternal mortality. Also controls family. So prevents pain related to dyspareunia, dysmenorrhea, chronic pelvic pain, pain associated with endometriosis. All these are benefited with COC, but side effects like bloating, many women complain bloating, sometimes nausea, vomiting,
breast tenderness.
breast tenderness. Yeah, this is very
Vaginal
common in many
discharge is
women.
also there.
And increase in
Difficulty
vaginal
in
discharge, that is also
breakthrough
common.
bleeding if not taken well.
That is very minor side effects. So you have to counsel your patient properly that they will basically focus on adverse effect. So you should tell them that what are the benefits, and with that you have to choose. They should choose their contraceptive things. Now, Dr. Reta, this is 28-year-old, 25-year-old women present with severe dysmenorrhea, chronic pelvic pain, diagnosed endometriosis. Under ultrasound, there is endometrioma. Also has mild acne and wants contraception plus long-term symptom relief and has no major comorbidity. So, what is the best medical management in this patient? What do you think? Again,
So,
same.
Risperidone or Dynogest containing COCs will be preferred.
Yeah.
Because that is going to suppress the ovulation, LH-FSH ratio decreased, and so less estrogen, and so the pain of endometriosis will be less. Acne will be also less because progesterone is less, and therefore LH is less, and therefore the androgenic effect is less.
So, COCs containing Dynogest, that is ethinyl estradiol plus Dynogest is the best because it is effective for endometriosis and preventing contraception also for this patient.
Yes.
So these are the now. Why is Dynogest particularly useful in endometriosis? Can you tell what are the benefits? How does it work?
So it will have long-term
Benefits ovulation,
effect
ma'am. Lower androgenic
on.
activity than progestogens used in traditional progestogen-only pills.
We have been discussing just now. Everybody has told about that. No? What endometrial atrophy does, ectopic endometrial tissue it suppresses, and thereby leads to decrease in pain, dysmenorrhea, and lesion suppression.
The effect is same as other than progesterone, ma'am.
Yes.
The side effects of the first generation progesterone is less.
Yeah. Again, for the acne and the androgen-related symptoms.
So basically, it is one of the good anti-androgenic progestins. So it will reduce overall production of androgen. It will reduce free available testosterone. So it will have a good effect in acne, but we do need to continue it for a long time, like 3 to 6 months for clinical improvement, or maybe for 6 to 12 months. But if woman has only got acne, then we can also advise her to go for some topical treatment as well. But definitely these type of anti-androgenic containing progestins or COC, they have good role in acne and other androgen related symptoms. It will also reduce the long-term effect of hirsutism as well.
Yeah, okay. Again, this is again same repetition only.
Yeah, advantages of Dynogest over older progestin is
I think someone is writing is 4 to 6 p.m. So we have exceeded the time. Someone has written.
Just a minute. Yeah.
Because
I
we
want
can best it is anti-proliferative, anti-angiogenetic, anti this thing for the cases of endometriosis. Just because it's a designer progestogen hybrid one, with the structure similar to that of 19 not testosterone progestogen derivatives. So better endometrial suppression is so strong for this. So it involutes all the ectopic endometrial tissue, and moreover it has got a anti this androgenic effect and no negative effect on the lipid profile. It is lipid, and moreover with it is friendly to glucose also. So the diabetics and somebody with dyslipidemia also can have this one.
So now,
can I
what
interrupt?
about
How much time, Pratima? More? I have to join another.
Just, madam. It was very big actually. You have given me such a big. The POPs will just talk and that's all. Okay.
Yeah.
So anybody, what are the different POPs?
Injectable, Mirena. There are so many progesterone containing contraceptives. Implants. There are also implants that can be given.
Intrauterine systems.
Yeah, and hormonal IV, that is Mirena. 4 types of progesterone contraceptives.
So POPs, how will you classify POPs normally? Low dose POPs or mono preparations are now available. Okay. So mainly it is classified. POPs containing traditional progestogen, which contain levonorgestrel, and it is used in the continuous administration without pause a day. And other is which has come POP containing lower progestogens, that is desogestrel and drosperinol. So they are used for the continuous administration without pause a day. And the other one with drosperinol is 24/4, which is more convenient for most of the patients. And we have just discussed about this also, what is its advantages and mechanism of action. Again,
thicken the cervical mucus.
Same thing, thinning of endometrium, thickening of the cervical mucus, and
decrease motility of the tube.
Yeah, and ovulation suppression. Now, what are the are the candidates for POPs?
So those who have got contraindication for POC, all of them will be ideal candidate for POP.
People, high risk of thrombosis,
Yeah.
postpartum.
So basically, who have the contraindication for estrogen? Okay.
So they will be ideal for POPs.
Ideal for this POPs. Now, Imrana, a 27-year-old women with traditional POPs complains of irregular bleeding. Now, what is this happening and what is the better alternative? How it can be improved?
Maybe she is not adhering to the she is non-compliant patient, and traditional contain 21/7, so poor cycle control. We can shift to something like 24/4.
Yes, that is what they say, that traditional POPs have a poor cycle control and incomplete ovulation suppression. That is why you must switch over to drosperinol, that is 24/4/1. That has a better cycle control and better ovulation suppression. And very importantly, 24 hours missed pill window. That is only protection. It gives protection for at least 24 hours.
Ovulation will not
miss the pills. Okay. So this is the action you can talk, Imrana.
Yeah, drosperinone has got a tremendous progestogen action and anti-adipogenic action, anti-androgenic action. So there is less acne, less sebaceous gland activity. There is less salt and water retention. It suppresses ovulation. For all those patients with PCOS, is wonderful, who are keep on bloating, and anti-mineralocorticoid activity is so very high with, and that is why it is it has got a wonderful, and it does not it has a good suppressive action on the ovulation, better cycle control, and
decrease in weight. That is important.
Weight neutral.
Yeah, weight reduction. So now you know how it is being used. Everybody knows, I think. Just give one line.
One tablet daily from the first day of the cycle. It is important because the first week of the starting of the contraception is the most crucial, because it is the time only when ovulation will be prevented, and not missing the pill in the first week is the most important window. And it has got 4 pill free days, that is from 25 to 28 days, and begin its subsequent pack on the same day of the week as the first cycle pack, because we have got a free 4-day window.
Yes.
Free, pill free.
And who can use drosperinol OC pills? I think everybody knows.
Breastfeeding, best.
Yeah, I think we have overshot.
Yeah. So, madam, I'll just switch it off.
PCO people.
And these are the different other contraceptives if you want to switch over. So I don't think so we'll be able to do this. Now next I will ask. Can anybody tell about what is the effect of POP on bone health?
To bone health, madam, oral POP
reduces
because it doesn't hamper the endogenous estrogen production. That's why it's neutral to bone mineral density.
So drosperinol is extremely beneficial in women with family history of osteoporosis.
Yeah.
It increases the tubercle reabsorption. So that is, and also inhibit the secretion of parathyroid hormone. Contraindication, practically there is nothing, no contraindication except breast cancer, because it stimulates the hormone sensitive tumor growth.
Liver disorders, migraine.
Yeah. This I'll quick skip. think this all we won't be able to cover now because time is very short. Imran,
Yeah.
we all know about this DIMPA. So what can you tell?
Can
Can it be used in the HIV patients?
we can.
Yes, we can use.
It is the eligibility criteria one, so it can
Give
be
DIMPA to
used.
HIV positive women.
Yeah. So it can be used.
Without restriction.
Yeah. Side effects?
Not so, but only there is sometimes amenorrhea, breakthrough bleeding.
Yeah.
These are the only side. Yeah.
So
Just
not much.
only side effect, not much more.
Yeah. And actually, implants also we wanted to talk, but I think we won't be able to take this now because time.
Yeah, it's I think very late, so we should.
Yeah. 32 years.
Close it. Yeah. Thank you so much.
So I'll just ask. I'll take one takeaway from all of you that what is the advantages of this contraception beyond contraception? I mean, apart from contraception, this thing, what are the other non-contraceptive benefits of this?
So can have improvement in bone health, can have some protective effect for cardiovascular function, some protection against endometrial and ovarian cancer and colorectal cancer as well. Good relief from dysmenorrhea, good cycle control and all those.
Yes. Okay.
Yeah, it's very good in cases of menorrhagia, endometriosis, and also in PCOS cases where we are using drospirenol, and it will reduce the acne and hirsutism and cycle control also.
Okay. So what do you think? Like young girls, agar PCOS के patients हैं, young girls हैं, and they are not sexually active. So which type of drug you should give to that patient?
So low dose hormonal pill we can give, low dose, young girls.
Okay. And what about the those who are?
We can give cipritolone acetate.
Yeah, that is the best because
we will give ciprotren if she is not sexually active. That ciprotolone acetate is better because it will prevent acne and hirsutism. It will cure everything. So better progestin ciprotolone in those cases.
Okay. Imrana, you want to add something?
I think everything has been added.
Anything else? How you will counsel the patient?
Male contraception.
What do you prefer in your this thing? Long acting contraceptive this
I
thing or
use
short?
Mirena only.
Mirena.
I don't put implants.
You don't play.
So
Implants it is
Mirena,
not available.
for as such Mirena, we should not use it only for contraception. We should not go for Mirena. So like better copper IUD or if she has got HMB, then only Mirena should be used.
But mostly these
Yeah,
days
even though it has got
incidence
both.
is so high for HMB and all. So it's better. Why not? Why? Because after some days with the copperty, they come with heavy bleeding only. Then adding tranexamic and all those things. So it's a better choice, I think. I mean, hope you all agree. I don't know.
Better choice what?
For regarding Mirena for contraception. Okay. Yeah.
So have you taken out also sometimes? Like if she's having heavy bleeding, so have you counseled or you have to remove the Mirena in that case?
No, Mirena only when dislocated into the cervical canal or somewhere, like after the involution of the uterus by its action, then only it will have bleed. She will have bleeding. Otherwise, she will not have. If it is fitted and we are regularly doing an ultrasound every year, then it's something which is wonderful. Unless it is dislodged somewhere or it has come because the uterus involutes the size in those adenomyotic cases or even in the normal cases, then we have to take care. We have to just think, go for an ultrasound for the monitoring if it is properly in situ or not.
Anything, Doctor? Anybody else want to add something, or we should close now?
Actually, contraception is a beautiful basket we are offering to patients. Should be individualized.
Yes, very
individualized.
So contraception should not be one size fit all, and it should be
More of awareness and sensitization is important because most of the times what happens is the people only know pari injection like DNPA, and one more important thing which I would like we should have a cell dedicated, like we are having ashas to take the patients for the delivery. We should have one cell for the contraception, passing on to the contraceptive benefits with all the choices spread out,
Yes.
so that we can, not only the doctor's load will be lesser and counseling them, and because all the brands, all the OC pills is given by the Indian government, even Centroman, you can have IUCD, even the
Any
levonorgestrel
Ashas are
daily.
also distributing these
No, but
contraceptives.
they are more towards taking the patient
Yeah,
towards the delivery and all.
Yeah.
It should be separated from this obstetric thing, and it should be only dedicated for the contraception. You look, Malaysia has controlled the population, being a Muslim country, just by contraceptive and implants.
Yeah.
And like we should advise them that
In
rather to go
DMK.
for oral pills, not the emergency contraception, because
Yeah,
many
that is
women we
important.
do see they prefer abortion kit in spite of these
Yeah, in spite of
pills.
this,
So we should tell
and
them that better to use we should use low dose COCs.
Rita, Dr.
yeah,
Rita, you want to add
Yes,
something?
ma'am. Yes, ma'am.
Pratibha
Health
ji, what I
education is
would
important.
urge you
All we have to
is
make
to
the
make the government
population aware.
through the government the format, and place it on a level that, since we are having, there are so many people who can just educate the people for the unsensitize them towards taking pills or taking the implant or taking anything which is for the permanent sterilization.
Yeah. Okay,
Like
Imrana, so
government has
we
got
will talk on this.
Maladi, they
And what
provide
about
Maladi.
Education and
Yeah.
So
awareness
they
is
should
important,
give
ma'am.
low dose pills instead of
Yeah.
Maladi and all.
Yeah.
Yeah.
Rita, you want to add, Dr. Rita, if you want to add
Yes,
something?
All that matters is, ma'am, awareness and health education. Once the
Yes,
patient
very
comes to
important.
know okay, these are the benefits and how I'm going to be benefited by this, by a good counselor, the things becomes easy.
So that is very important. So thank you so much. Thank you all
Thank
our
you so much,
experts and
ma'am.
panelists for the
Thank
excellent
you,
and
Pratibha
practical
ji.
discussion. And
Thank
like
you, ma'am. Thank you, Pratibha, ma'am.
and
Thank
thank
you,
you
ma'am.
and
Giving
thank
this
you, madam, for
opportunity.
giving us this extra time. Actually, I
I
was
know
not able to.
this hormones PPT is little longer, okay?
I mean, it is very
So
long.
very long. But you
Yeah.
know, I'm so happy with everybody's responses and the concern and the way they want it to be. I mean, to motivate people and all that. And I agree that now in a district hospital they have a counselor. See, we have a
Yeah.
separate room
Yes.
where
Yes.
we have put up all these IEC material. So in a busy OPD, what happens? Nobody counsels the patient. But I think government has taken the initiative, like PPIUCD. Now
Yeah.
we have Implanon also for IUCD, PIUCD, and even the medical officers are trained for PPIUCD, PIUCD, and regarding the contraception. So, but that is not enough. Public also have to be. I mean, they also have to worry about their own health. You know, they
Yes.
will have a
Definitely.
smartphone, but they will not check that. They will come take a pill across the counter and come to us.
Yes.
So that I think all of you, if you have no local people and some, you should distribute. I mean, you should spread this message about one is the MTP pill is not a method of family planning, regular contraception.
Emergency.
Yeah, and all those things. But I must tell you, Pratibha,
Yeah.
हमारे पास फॉक्सी में इतना टैलेंट है मैं बोल रही हूँ ये हिडन है since I am doing this 7H CME I am so happy that
Yes,
I
madam.
come to know that सब लोग इतना I mean involved है और इतना अच्छे से हो रहा है I am really so happy.
No, this I think
All
this
of you.
this PPT is very good, but it should be divided into two because
Yeah,
together
that
it's
we can
very
do.
difficult to
That I
take.
realized today. You
Uh,
could have, I mean, yeah, we could have done that. Yeah, okay.
so so
I will share
thank you so
those.
much, madam, for giving me this opportunity. Thank you so much. Now, shall we have a vote of thanks? Shall we propose vote of thanks?
And thank you all. Okay.
Thank you,
you all
ma'am.
Thank you
for
so much, everyone,
yeah.
for your active participation. And thank you so much, Sheila Mane ma'am, for organizing this webinar. Special thanks to Pratibha ma'am for giving us this opportunity. Thanks to all the chairpersons, the speakers, all experts, and such insightful comments from everyone. And we are really sorry, Devdas sir, very short. We really exceeded the time. We are really sorry for that. So thank you so much, everyone.
Thank you, thank you, thank you, sir. Thank you, sir, for staying till last. Thank you.
Thank you. Bye. So see you all in Bangalore.
Yes.
प्रतिभा सबको
हाँ,
लेकर आओ.
बिल्कुल बिल्कुल मैडम. Everybody should come to Bangalore. ICOG. Yeah.
Sure, ma'am.
Bye.
Okay. Thank you.
Bye.
Leave.